Okay, so let's start this session. This session is known as your OQR, ophthalmology quick recap. And in this particular session, I will gonna cover all the high yield topics, which is the exam oriented, as your exam is on your 6th July, right? So I hope you had the full session or the full classes of the ophthalmology from any faculty, right? So now I will take all the high yield topics in this particular video, right? So let's start this session. Okay, so starting with this session with the basic of it, and in the starting on the session only, I will introduce myself as I already introduced. My name is Dr. Vaibhav Ahuja, and I'm your ophthalmology faculty, and I will gonna take your this OQR session, ophthalmology quick recap session, right? So if you want to know about anything related to the ophthalmology, have any queries related to the ophthalmology, so you guys can contact me directly on my social medias, and my social medias are my Instagram is here, dr.vaibhav This is my Instagram handle, and my Telegram username is dr Vaibhav Ahuja, right? And already I have an ophthalmology channel also, so you can join that also, right? So starting this session with the first slide of this session is the anatomy and physiology of the eye. So first of all, you have to go with the revision of the anatomy. So in the revision of anatomy, first of all, I will talk about the eyeball, right? So as I start with the eyeball, so in the eyeball, we have to go with the some dimensions. So the dimensions are there. So we have to learn by heart this dimension, because these are the mathematical values are there, guys, right? So we have to go with it. We have to remember this particular values of dimension. So what is the dimension in the eye? As you already know, eyeball is a kind of a ball like structure, okay, round shape, or you can say the orange shape structure, right? Round shape structure is there. So we have to see the all the dimensions of it, right? So if I'm talking about the dimensions of the eyeball, I already shown you a diagram is invisible. It's visible to you on the screen. I will surely try to make all the type of dimensions also here, right? So starting with the first one, the first dimension is here your anteroposterior diameter. So in the anteroposterior diameter, if I'm talking about the anteroposterior diameter, what is the about the anteroposterior diameter? In the your anterior posterior diameter, we have the anterior pole of your eyeball. I hope you can see here, right? This is the your anterior pole of your eyeball, and we have the posterior pole of the eyeball, right? So it is a direction. This anteroposterior diameter is from the anterior pole. We are counting it till the your posterior pole. So from anterior pole till the posterior pole, it is your 24 mm. If I'm talking about the diameters, it is your 24 mm, right? And now we have to talk about the second diameter. The second diameter is your vertical diameter. And as you already know, the vertically, it means it will be lying on like that. Okay, so vertically, so the vertical diameter will be your 23 diameter, right? 23 mm will be there, right? The third one, which is your horizontal, the third one, which is your horizontal, I hope you understand this thing. This is the horizontally will be there, right? So the horizontal diameter will be your 23.5 mm. Now it is a nearby and the similar things are there, so I make a mnemonic for it. So I hope you have to remember this mnemonic. This mnemonic is your AHV, right? So we have to remember with the AHV. And what is the mean of AHV? A is your anteroposterior, H is your horizontal, and V is your vertical. So now out of this, what will be the mnemonic? Yes, just what you have to do, you have to write it down like 24. You have to remember one value, just minus 0.5 value to 23.5, and just also minus the zero point 0.5 from here also to 23. So it will be quite easy for you. So remember with AHV, right? AHV, right? Anteroposterior, then your horizontal, and then your vertical, right? So this is a quite easy manner to understand this thing. Also, they can ask you sometimes the circumflex, the whole circumflex of the eyeball is your 75 mm, 75 mm. The important things which is already asked in your exam, that is your volume of an eyeball. So what do you mean by the volume? Yes, the volume of our eyeball, each eyeball is having 6.5 cc. Please remember, it is a each. Okay, I'm not talking about the both of the eyeballs, right? Both are the different having the 6.5 and 6.5. Okay, so totally, if I'm talking about one eyeball, the one eyeball is having the volume of 6.5 cc. Okay, and if I'm talking about the weight, if we're talking about the weight, we take it out the eyeball and doing the weight of it, so that it's near the 7 gram, right? So what is the values of your eyeball? Yes, your eyeball's weight is your 7 gram, right? So the 7 gram is the actual weight of your one eyeball, right? So this is about your all the diameters which is the related to your eyeball, right? I hope you remember this all the eyeball. Is it okay for you? Should we move forward for the next slide? Is it comfortable for you guys? Let me know. Let me know in the chat box. Perfect. Okay, diameters yaad ho jayenge. Diameters will be understandable for you, right? Very good, right? Quite easy. Just remember the mnemonic. Just remember the mnemonic AHV. So it will be easy for you to remember this. So for easy for you for remembering this, right? And although it's quite easy, 6.5 mm, the 6.5 cc is your volume of the eyeball. And if we're talking about the weight, it will be near the 7 gram, near the 7 gram. Okay, let's move forward for the next. Although now we have there is a division eyeball, as we talked about all the dimension of the eyeballs. Now first of all I will introduce about the eyeball is having the structures. So one by one we'll go with all the structures. So starting with the from the anterior most is your cornea. So I hope you know about the cornea. The cornea is your transparent structure, is the anterior most part of your eyeball, right? After this cornea, in the anterior most layer also we have the sclera also, right? So the your cornea and your sclera, these both are making your outer fibrous coat. What is making? It is making your outer fibrous coat. So what is your outer fibrous coat? It is a fibrous coat, right? It is the outermost coat or outermost layer of it. We have the three layers in our eyeball, right? You already know the outermost is our outer fibrous coat. In fibrous coat, the name as the fibrous coat, it means it is having some fibers, so it will be hard from the outer side, right? So provide the protection for it. It will provide the protection to our eye, and it is keeping all the contents in the shape, right? So the eye shape and container we can say, and the protection the eye ocular contains. So the cornea is the outermost, is the, if I'm dividing it the outermost layer into the two parts, so the cornea is having the 1/6 part of it, and the other part is a white translucent part, which is the 5th, 6th part of our outermost layer. It is by the sclera, right? So what is the mean of your cornea? I think you already know about it, as you had already the classes you had, or you had the lecture of it. So you remember about it. This is the outermost layer. Your outermost layer, your outer fibrous coat is having the two structures, cornea and your sclera. So the cornea is having the transparent structure. It is a transparent, and it is participating in our refraction also, right? So the importance of the cornea is what? The first importance, that it is the outermost part of, or the outermost layer of our eye, right? The second thing, it is participating in what? It is participating in our refraction part, right? So this is about our cornea. If I'm talking about the sclera, as you already know, this is the translucent part, and all the extraocular muscles will be going to attach to our sclera, and all the minor vessels and the nerves will be going to pass through this. Okay, so this is related to that. If I'm talking about it, the more deeper, if I'm going more deeper, so it is about the first layer. It is the outermost layer. The second layer, if I'm talking about now second layer, the second layer is having first structure, which is your iris. So what is the iris? Iris is a pigmented layer of our eyeball, and it is having the pigmentation, right? Having the color. It is identification for using for the identification. After the iris, we have the ciliary body, which is known as also the ciliary muscle. And the last one, which is the background, we have the choroid, right? So we have this choroid here, right? You can see here, this is a choroid, right? This is a choroid. Okay, so this choroid is also the vascular structure. So out this all the three, the iris, the first is your iris, second is your ciliary body or the ciliary muscle, and third is the choroid. This all three is included, is known as your middle vascular cord. It is known as your middle vascular cord. It is known as your middle vascular cord. So it is having, as the name is only the given middle vascular cord. The middle, it means it is in the middle. We understand this thing. And vascular cord, it means it is having the vascularity. What do you mean by the vascularity? All the blood vessels, all the blood supply, the major blood supplies of this our eye is supplied through by this all by this three structures, right? So this is the vascular structures are there: iris, ciliary body, and the choroid is your vascular structures. Okay, so this is about your middle vascular cord. And if I'm going through the last one, which is your third layer, and third layer is your inner nervous cord. Inner nervous cord. And this our inner nervous cord. Our inner nervous cord is having only one structure, which is your retina. I think you remember this. This is your retina, and this retina is your neural perception, is participating in your neural perception, and the most important part of our eye, right? So this, if you're talking about the physiology of it, so you remember this. The physiological work is from your retina, is having the cells, is the cones and rods, right? So it is participating in the our night vision, or you can in the night vision also, and in your bright vision also, right? So rods and the cones will be participating in this. The rods and cones will be participating in this, right? So this is having on the retina, okay? So let's move forward for it. So this is about all the layers we talked about, all the layers. I hope you remember with this. Now about the layers, you understand this thing, right? Let me know in the chat box if you understand about the layers of it. Then we'll move forward. Then I will move forward for the next. Reply me in the chat box, guys. You understand this thing? Very good. Very good. So layers are completed. Okay, layers are completed. Now after the layer, we have the some contains also. What we have the content in the our eyeball. So if I'm talking about the content, so most important content is your lens. As you already know, it is also participating in your refraction and accommodation also, right? So this is the most important part of the our eyeball, is talking about the content. The second content, you can say it is the vitreous, which is filled in your posterior segment, and it is a gel like structure. We'll talk about it also. So this all the posterior segment will be filled by your this gel-like structure only, which is known as the vitreous. And we have one more important, which is your aqueous humor, which is your aqueous humor. Okay, so this aqueous humor is having filled within your anterior segment, and the anterior segment is already filled with your aqueous humor, right? And this aqueous humor will be going to supply the your all the nutrition to the your avascular structures like cornea and the cornea and the other lens, right? So if you're talking about it, so this is about all the contents and the codes. So there are the three codes and the three contents which you already know, right? So let's erase it, and now we have to talk about the important thing, which is the chambers and the segments. So eyeball is having divided into the two segments, and then further this segment is divided into the chambers, right? So if I'm talking about it, first of all I have to talk about the segment. So how many segments we are having? So of course we have the two segments. So how many segments we are having? Write it down in the your PDF or in your workbook. So how many segments we are having? The segments we are having the two segments. What are the two segments? As we having, the first is your anterior segment and the second one is your posterior segment. And further, the anterior segment is further divided into the two parts, that is known as your anterior chamber and the posterior chamber, right? So I hope you understand this thing, that we have to, first of all, we have to divide our eyeball into the two parts, which is the major parts, which is your first is your anterior part, which is the anterior segment known as the anterior segment. The second one is the your posterior part, which is your posterior segment, right? After this, then we have the this anterior segment is further divided into the two parts. That two parts is known as your anterior chamber and the posterior chamber, anterior chamber and the posterior chamber. So how it will be going to divide it and which structures are including in it, so we have to talk about it. So just just draw with me, you will understand it. So as I have to divide anything into the two parts, so I have to take a landmark, or I have to take a particular landmark, so I can divide it into the two parts. Okay, so for the making the segmental landmark, I have to take the landmark as a lens. So as I'm drawing an imaginary line here, can you see with this black color marker, I'm drawing a line here. This is drawn with the, this is your imaginary line. It is known as your imaginary line. And this imaginary line, which is the on the base of your lens. So, okay, so how I draw the lens? I draw an imaginary line on the lens, right, on the basis of the lens. So it is anterior part to this imaginary line. To anterior part to this imaginary line, this all is known as your anterior segment. It is known as your anterior segment. Please try to understand this thing. What are the segments? It's quite easy to understand to you, right? Very good, right? So this imaginary line is here, so it's divided into the two parts. That anterior one is the anterior to the your this imaginary line is your anterior segment, and this posterior one to this imaginary line, this posterior one is known as your posterior segment. Okay, so as I divided this eyeball into the two parts, the first of all is your anterior segment, which is the anterior to this imaginary line, and the second one is your posterior segment, which is the posterior part of your this imaginary line. Okay, so this is the known as the posterior segment, right? So I hope you understand about it, about the anterior segment and the posterior segment. Now I'm zooming in into it. And little bit going into the depth, that I have to divide this anterior segment also. So for the dividing the anterior segment, as you can see, the anterior segment is the anterior most part of this imaginary line. So I have to divide it also. So for the making the division of it, so going to make it the division of it, I have to take a landmark also. And the earlier time for the dividing the segments, I choose the landmark as a lens. But this time I have to take the landmark iris. So as I'm drawing this again, one more imaginary line into the anterior segment. and this imaginary line will be going to divide our anterior segment into the two parts. Okay, it will be going to divide it into the two parts, right? So you can see here that the anterior to this iris, this imaginary line, which is the from the blue color I drawn here, this anterior most part, this anterior part to this all is known as your anterior chamber, and the posterior to this till the here, this part is known as your posterior chamber. Okay, so this is about their anterior chamber and the posterior chamber. It is quite easy to understand. I'm trying to make simplifying to understanding you this about the chambers, right? Otherwise, always in the books and the notes, it's rightly just written that anterior chamber, this is structured in the anterior chamber, this is in the posterior chamber, and you're not understanding what is the anterior chamber and what is the posterior chamber, right? So now I divided into the, I divided this eyeball into the part. There is a segments also and between the chambers also. Now let me know in the comment box and in the chat box just that did you understand about this segment and about the division of your chambers, yes or no? Firstly, let me know in the chat box that did you understand or not. If you understand, then we'll move forward. If you understand, then we'll move forward for it, right? Very good, right? Very good. Okay, so this is all about, you have to see all about the your segments and the chambers. If you understand about the segment and chamber, now it will be quite easy for you. Now it's quite easy for you to understanding the things when I'm going to tell you in the diseases part, right? Okay, let's move forward for the next thing. That's we have to talk about the orbit. What is the meaning of the orbit? We talked about the eyeball. This is your eyeball, right? You can see this is your eyeball. Okay, this is your eyeball, and this eyeball is situated in a bony cavity. This eyeball is situated in our skull in a bony cavity, and this bony cavity is known as your orbit. Okay, so this bony cavity is known as your orbit, right? So we have the eyeball. As you already know, this eyeball is situated into our skull, right? Inside the skull we have this situated, this we are inside the skull, in this bony cavity we have situated this our eyeball. So this eyeball is situated in the bony cavity. This bony cavity is known as your orbit. This bony cavity is known as about the orbit. Now we have to talk about some dimensions of our orbit also. So let's talk about it, about the orbit. So if I'm talking about the orbit, the first of all, the volume of the orbit, if I'm talking about it, it is the total volume of it is the 30 cc. How much, guys? It is your 30 cc. 30 cc is the volume of the orbit. And you already know the what about the eyeball? As I already told you, how much for the eyeball? Can anyone of you can tell me in the chat box how much for the eyeball? Let me know in the chat box how much for the eyeball. Yes, it is your 6.5 cc. 6.5 cc, right? So the 6.5 cc is your eyeball. So this is occupying only the 1/5 of the volume. Okay, so our eyeball is occupying from this orbit just only the 1/5 of it, right? Near the 1/5 of it, the eyeball, right? If I'm talking about the important questions, mark as important this, they can ask you that which is the your thinnest wall of your orbit. So we have the orbit. Orbit is like a cavity, right? So this cavity will be surely having the 4 walls, right? What are the surely 4 walls will be there? The one which will be the roof, the second will be the your floor, the third will be your lateral side of the wall, and the one medial side of the wall of the orbit, right? So this is having the 4, this is having the 4 walls there. So if I'm talking about the thinnest wall, which is the thinnest wall will be there. So thinnest wall will be your medial wall. So our medial wall is our thinnest wall. Okay, so the medial wall is our thinnest wall of your orbit. And if I'm talking about the thickest wall, if I'm talking about the thickest wall, guys, again, so the thickest wall should be your lateral wall, right? So now I will talk you about in the deep also that which bones are going to make this participation of this orbit, right? So we'll talk about it. Just remember about it, which is the thinnest. Reply me in the chat box. I'm waiting for your comments in the chat box. Which is the thinnest wall? Which is the thinnest? I'm talking about the thinnest. Which is the thinnest wall? Reply me in the chat box. Very good. Okay, and which is the thickest? Now tell me about the which is the thickest. You told me about the thinnest. Now tell me about the thickest. Which is the thickest part? Which is the thickest wall of the orbit? Very good, very good. The lateral wall of it. Okay, surely I will tell you about the bones also related to this. We'll talk about it about the bones also. Now understand the thing. If the floor, if I'm talking about the floor, the if floor is the more commonly going to involve in the fractures, and this particular fracture is known as named fracture, which is known as the blowout fracture. So please remember for it, what is the mean of your blowout fracture? Yes, your blowout fracture is the fracture of your orbit floor, right? So if orbit floor is getting fractured, it is known as your blowout fracture. Blowout fracture. Surely we'll talk about the blowout fracture also. If I'm talking about here only about the blowout fracture, so it is having what? It is having, there will be the your scene of your the first of all there is the loss of sensation. Write it down. Loss of sensation below the eye. Okay, so just below to the eyeball here, we will lose the sensation because as it is a floor fracture, so in the floor we have an infraorbital nerve. So this infraorbital nerve will be going to damage. So this inferior part of your our eyeball, or just below to the just below, you can say the inferior to the, writing down it's much better, would be the loss of sensation into inferior to the eye. Okay, so the inferior part of your eyeball will be getting loss of sensation, the first of all thing, right? Also, as this will be looking like that, the eye is gone inside, so it is known as your ophthalmos. Okay, so what do you mean by the in ophthalmos? Yes, in ophthalmos, the eye will be going to inside, because now as the floor is getting damaged, so this eyeball will be moving inside, the content will be moving inside, and it is known as your in ophthalmos. And also we have the ecchymosis. Ecchymosis will be there. What is the mean of ecchymosis? This eye will be getting the accumulation of the blood. Accumulation of the blood will be there. Voice is low. No, I think its voice is perfect. What about the others? Tell me, what about the others? Voice is perfect. Let me know in the chat box. This voice is perfect, guys. Just check once from your end, guys. Okay, my voice is perfectly. I'm seeing on the other screen also the voice is going perfectly. Okay, right. Okay, so we'll talk about it. The ecchymosis, the blood will be going to accumulated near the eyeball, and it is looking like a blackness on the near the eyeball. So it will be your ecchymosis. The three things will be seen to here. And if I'm talking about it, what is the most common cause of your blowout fracture? So it is the sudden increasing into the your IOP. Okay, sudden. Please remember, it is sudden increasing. And what are the causing of the sudden increasing the your intraocular pressure? The first is your fist injury. The fist injury, although I can talk about the cricket ball injury. Cricket ball injury. Yeah, tennis ball also. Sure, sure, sure. Okay, we can write tennis ball also, right? Exactly. Tennis ball also. Okay, so what is happening as your fist injury, tennis ball injury, cricket ball injury, this will be going to directly going to making a blunt injury on the your eyeball, right, and on the orbit, right? So due to this injury on this orbit, what is happening? Sudden increasing in your intraorbital pressure. So intraorbital, not in the intraocular, guys. It is, I'm talking about the intraorbital. What do you mean by the intraorbital pressure? The orbit is also as a cavity, it is having the own pressure. So if it is a sudden increasing in your intraorbital pressure, so it will be going to fracture of your floor of your the floor of your orbit, right? So this is all about your blowout fracture. I hope you understand about it, about the blowout fracture very well. The important thing, if I'm talking about the radiology also, so what will be the scene on the radiological side? Anyone of you can tell me in the comment box, right? Anyone of you can tell me what will be the about the from blowout fracture, which on the CT scan, please remember, on the X-ray also you can see, but it will be clear on the CT scan. The CT scan, we're gonna see what? We're gonna see the teardrop sign. Very good, doctors. Okay, so the teardrop sign will be seen. Okay, the teardrop sign will be gonna seen to you in the CT scan, right? So this is all about the importance about your blowout fracture. Let's move forward for the next thing. It is all about your orbit wall. So in the orbit, we have the walls of the orbit, which is formed by the different bones here. So we have to talk about all the bones, and you have to remember with it set which is made by from the which bone, right? So if I'm talking about the first of all, as I already told you, it is having the four walls. So first of all, it is the medial wall. The first one is the medial wall. The second one is your lateral wall. The lateral wall. The third one is your superior wall, or you can say as a roof. As a roof, we can say it's as a roof, right? And the fourth one is your floor, which I already mentioned here also, that commonly involved in your blowout fracture, right? So you will remember about the blowout fracture. I think everything is clear about the blowout fracture also till now, right? So let's start with the first of all, we'll talk about the medial wall. If I'm talking about the medial wall, which side of the medial wall will be there? Near the nose, right? So near the nose, this is the we having the two orbits are there. This near the nose, this wall is known as your medial wall, and this medial wall we have the bones are participating to making this wall of the orbit, medial wall of the orbit. The first one is your frontal process of the maxilla. The first one is your frontal process of the maxilla. So this the frontal process of the maxilla will be going to participate there. So it will be also, it will be going to participate in the your medial wall. The second one, which is the smallest bone, you already know that is this lacrimal bone, very small bone, which will be participating here. I will show you about this bones also. I will show you the bones also. Just wait for it. Okay, doctor. Right. So this is about the lacrimal bone, and also we have the cribriform plate, which is participating in your orbit, making the part of the orbit, and your ethmoid bone, right? On the ethmoid bone, these two bones have also the very small participation of it, and the body of sphenoid from the back side, it will be participating in the, it will be going to participate in the medial wall. So let's revise with me. What are the four important or the five important things are in the medial wall? First of all, frontal process of the maxilla. The second, lacrimal bone. The third is our your cribriform plate and the ethmoid bone, and the fourth one is your body of sphenoid. Just check it out with me. So this is the image of, this is a particular image of your orbit, right? So this is the skull, and through this skull you can see this is the your orbit. So through the orbit, as I can show you, this is the medial wall. So this one is your medial wall, right? This one is your whole medial wall. So if I'm talking about the medial wall, as I already told you, the first of all, it will be the making a maxillary frontal process of the maxilla. So you can see this one is the first one, which is your frontal process of the maxilla will be going to participating in here, right? After the participating of this your frontal process of the maxilla, the second one, which was bone we were having, this the lacrimal bone. So you can see this is the second bone, which is your lacrimal bone is here. This is the second bone, which is your lacrimal bone is here. And after your this lacrimal bone, we have the some part of your ethmoid bone also. So this part, which is the smallest bone, is here. The background, it's this will be your ethmoid bone, right? So I'm writing here the third one. So this will be your ethmoid bone, and the part of cribriform will be here. And the last one, which is the fourth one, which is the body of sphenoid. So you can see this yellow part, which is participating here. This is our body of the sphenoid. This is having the body of the sphenoid. So I hope now you can understand this thing. This is the medial wall, right? So in this side, you can see this is the medial wall. This side of the medial wall of this left side, this will be for your right one, right? So this both of your medial wall, and I shown you all the bones which are participating in your wall of orbit into your medial wall, right? After this medial wall, now I'm moving forward for the next part. Now we are moving further for the lateral wall, right? Now we are moving further for the lateral wall, and in the lateral wall, just we have the two things. What are those two things? The zygomatic bone, the first one, and the second one is your greater wing of sphenoid, right? So just check it out, which is your lateral bone, right? So your lateral wall will be here. So this is your lateral wall, and out of this, in the lateral wall, you can see the two bone. The first bone is your, this is your zygomatic bone, the first one which you can see, and the greater wing of sphenoid is the yellow color bone, which you can see on this posterior side of it. So these two bones are participating in just in our lateral wall of it, right? So now I can remind you once again. So this one, the medial wall will be your thinnest or thickest. Tell me in the chat box, thin or thick. Tell me fast. Thin or thick? Medial wall. I'm waiting for your answers, guys. Thin or thick? Everyone should reply in the chat box. Yeah, it will be your thin. And what about your lateral wall? What about the lateral wall? What about the lateral wall? Thin or thick? Thin or thick, guys? Tell me fast. Very good. It will be your thickest. Okay. So that's why now understand the thing. As there is the more bones are participating in the medial wall, right? So it is having the more over the joints will be there, and these joints are not too much strong is there. So that's why this is the thinnest wall and easy to break, right? Easy to break. But the thickest wall, because there is only two bones are there, and it is a very big bones. Although in the medial wall also we have very small bone, ethmoid, lacrimal. These are very small bones. So that's why this is your making the medial wall very weak or the thin. Okay, we can say the weak also. Let's move forward for the now superior wall, or you can say the roof. If I'm talking about the roof, so roof is also made by your two things, the two bones, which is the first one is your orbital plate of your frontal bone, and the lesser wing of your sphenoid. So if I'm talking about the sphenoid bone participating in the as a body of is participating in your medial wall. Although your sphenoid greater wing is participating in your lateral wall, and your lesser wing of your sphenoid is participating in your superior wall, right? So here we have the two things, guys. Please understand the thing. There we have only the two things. What are those two things are here? What are those two things we have? These two things we have only the first one is we have the frontal bone, and the second one we have after the frontal bone we have the your sphenoid, right? So which is sphenoid? We have the lesser wing of sphenoid. What we have? We have the lesser wing of sphenoid. Okay, so let's I show you in this diagram also, so it will be quite easy to understandable for you. So you can see here, this is the roof, right? So in the roof, if I'm talking about it, this will be the first bone, which is your frontal orbital process of your frontal bone, and the second one, which is you're having the lesser wing of sphenoid. So this is our lesser wing of sphenoid in the behind. So this is the two bone which is going to making, which will be going to making your part of, just a minute, going to making the part of your is part of your sphenoid. Okay, so this is all about the your part. This is the all about the your part of. Yes, anyone is raising the hand? Any one of you are raising the hand? Please let me in the chat box if you have any queries. Please let me in the chat box. Okay, if you have any query, let me know in the chat box, guys. Write in the chat box. It will be quite easy for me to reply. Okay, very good. Okay, let's move forward. It is about your roof. Now after the roof we have to talk about the last, which is your floor. Okay, which is your floor. If I'm talking about the floor, as I told you, the floor is floor of fracture. The fracture of your floor is your having the known as your blowout fracture, right? So you have to remember this three bones importantly which will be there. The first one is your orbital surface of your maxillary bone, although the second one is your orbital surface or your orbital surface of your zygomatic bone, and the last one is your palatine bone. So if I'm talking about it, let's check it out. This also, if I'm talking about it, you can see here, this one will be your maxillary part of the orbital part. This one, the first bone, right, in the floor. The second one is the zygomatic bone part, and the third bone will be not visible here because the palatine bone is the your from the in the mouth. The roof of your mouth is your having the palatine bone, so it is participating. It will be participating from the inferior side. How it is participating? Yes, it will be going to participating as in the floor. It is participating from the your inferior side. So it is the your third is the last bone, which is a palatine bone. I hope you understand about this all of it. Just tell me in the chat box once. Is it clear to you about the all the orbit wall? About the all the orbit wall, all the important MCQs and all the bones I covered here, right? I hope it's quite easy to understandable for you. Just remember about it. If they are asking weakest or the thinnest wall, it will be your medial wall. If they are asking about the strongest and the thickest wall, it will be your lateral wall. And you already know it is the floor of fracture. Yes, floor fracture or the blowout fracture of is known as the floor fracture is known as your blowout fracture. Right? Should we move forward? Sure. Should we move forward? Okay. Okay, guys. Sure. Okay, let's move forward for the next thing. And in the next thing, we have just a minute. Yeah. And the next we have to talk about, now we talked about the your orbit also. Now we have to talk about the one by one all the structures which we have to talk about it. So as we have this cornea, as this cornea is your outer fibrous coat, as I already told you, this is the part of your outer fibrous coat, and in the outer fibrous coat it is having only the 1/6 part. Okay, just only very small part. If I'm talking about it specifically about the cornea is your transparent structure. The cornea is your transparent structure, and this is having the dehydrated and the avascular structure. Please remember the avascular structure. Yes, your cornea is not having any kind of the vascularity. Now your mind is saying, sir, if the cornea is the avascular structure, this if it will be getting how it will be getting its nourishment. Okay, how it will be going to getting the nourishment of it. So for the nourishment of it, it will be provided the nourishment, and the hydration will be from by the your aqueous humor, as your aqueous humor is filled in your anterior segment, in the anterior chamber also, and in the posterior chamber also, right? Anterior segment is further divided into the anterior chamber and the posterior chamber. So the both of the filled with your aqueous humor. It's a water-like structure, right? So it will be going to give the nourishment and your hydration to this your cornea. Now, if I'm talking about it, it is forming your 1/6 part outer for your outer fibrous coat of the eyeball. We already talked about it, and the two important things which we have to talk about it, that is your important part. It is the refractive power of your cornea and the refractive index of your cornea. So the refractive index, now you're talking about it. Yes, sir, we already know about the refractive power. The refractive power of your eyeball, your cornea is your 44 diopter. 44 diopter. If I'm talking about it, if I'm taking into the range, it will be your from uh, 42 to 46 diopter. Okay, it will be 42 to 46 diopter, right? If I'm taking a range of it, right, it is not the constant in the same in the everyone, like in the newborn also, in the adult age also, and in the older age also. So if I'm taking about a range, so range will be surely from your 42 to 46 diopter will be your range of it. But now we have to talk about your refractive index also. If I'm talking about the refractive index, so I hope in your physics you already studied that every media is having their own refractive index, right, to making the going to the refraction into it, right? So our cornea is specifically having the our cornea is specifically having the structure of the we can say the refractive index of 1.33. Okay, just you have to remember the values that the refractive index of our cornea is having the 1.33, right? So refractive power is the 44 diopter. If I'm taking as a if I'm taking as a range, so the range is from the 42 to 46 diopter, and there will be the 44 diopter, right? Just remember about it. If in the MCQ they're asking into the range, then mark as a range. If the option is given like that 40, 42, 44 and 46, so just go with the 44. Okay, if the single answer they're asking, go with the 44. Okay, let's move forward. It's about the cornea, and in the cornea also we have to talk about now the layers of the cornea. So as you already know, earlier it was in the older edition it was a 5 layers, but in the now latest AK Khurana it is having the 6 layer, right? So this is all the notes are made by my own, and it is from the your book. If I'm talking about the book reference, if you want to ask me, so the book is referred as the AK Khurana, right? From the AK Khurana edition 6, right? Edition 6 is your base of this your notes, right? So now we have the 6 layers, right? Now we have the 6 layers of our cornea. In the cornea we have the first layer, which is the outermost layer, you can say the outermost layer, which is known as your epithelium. As you already know, epithelium, it means the outermost layer. By the name you can understand epithelium. So which kind of epithelium we are having on the cornea? So we have stratified squamous epithelium. Please remember, non-keratinized. It is a stratified non-keratinized. Okay, so there is a two type of the stratified. So this is a non-keratinized. Okay, if you're talking about it, it is a non-keratinized. It is a stratified non-keratinized squamous epithelium. Okay. In the next layer after the epithelium, we have the one more, the second layer. It is known as your Bowman's membrane. The second layer, it is known as your Bowman's membrane. What is the importance of this Bowman's membrane? Just remember about it. Maybe due to the trauma, due to the penetrating trauma on the cornea, right? So due to the penetrating trauma of the cornea, the layers are getting damaged. So if your Bowman's layer is getting destroyed once, so it will be not getting regenerated. Okay, all other 5 layers can be regenerated again. The cornea will be back to the normal as the recover after the recovery, but your Bowman's layer will be not there, right? So if any patient you are in the clinic, in your ophthalmology clinic, one patient is coming to you and you are saying there is a Bowman membrane is absent, so you can ask that patient, do you have a history of the trauma to the your cornea? Maybe there the penetrating trauma will be there, right? So the third layer, now we have the third layer is the stroma layer. And importantly, the stroma layer, it is your thickest layer, right? It is your thickest layer, you can say, because the 90% of the thickness of the cornea is contributed by your stromal layer also, right? So this will be your thickest layer of the cornea. So if they are asking you the thickest layer of the cornea, it should be your stroma layer. It should be your stroma layer. And also we have the Duas layer. This is the new layer. You can write here. This is the new one. Okay. So the new one. What is the new one in the Duas layer? Yes, it is discovered in the 2013, right? It discovered in the 2013 in India only. So that's why the doctor's name was the Dua. So it's named as the doctor's name only. They keep the layer's name is also already as the name as Duas layer, as a Duas layer. Although we have the fifth layer, it is known as your Desmond membrane. right? It is a very important, and it's the important thing is that as once it will be getting destroyed, it can be regenerate, right? Yes, so a Descemet membrane can be regenerate, and your Bowman's membrane cannot regenerate. And the last one, which is we are having the endothelium. Endothelium, it means the innermost. Endothelium, it means your innermost of the layer, and the innermost layer we are having the endothelium. The innermost layer, what we have? The innermost layer we have the endothelium, and this endothelium is the most metabolically, this is the having the mostly metabolically active layer, right? So if I'm talking about the your layers of the cornea, so this is the most active layer of the cornea, right? Most metabolically active. If I'm talking about the most metabolically active corneal layer, so what it is having? Yes, it is having a sodium potassium ATPase pump. What is this having? It is having the sodium potassium ATPase pump, right? So this sodium potassium ATPase pump, yes, the sodium potassium ATPase pump only is doing, the sodium potassium ATPase pump is only doing the transferring of, making a transferring of your all the nourishment of your corneal layers, right? So making a your hydration of your cornea, or the making your the supply of the nourishments to the cornea through this layer only, right? So this is about the layers of the cornea. Right now, tell me in the chat box, guys, if the speed is okay, or you want that I will increase my speed or decrease my speed. It is understandable for you, because I'm a little bit going faster, because as it is the, I already told you, it is your OQR, right? Ophthalmology quick recap, right? So in the ophthalmology quick recap, you have to go with a quick manner, okay? If you want, I can increase also. If you want, I can go with the same speed. Just let me know in the chat box. Okay, okay, perfect speed, right? So I hope you already had this all the information. So that's why just we are revising it, or we are going with a quick recap of it, right? Moving for the next layer of your outermost layer, or the outer fibrous coat. Out from the outer fibrous coat, we have the sclera, right? So first was the cornea, the second one we have the sclera, and this sclera is forming the fifth, sixth part of your outer fibrous coat. This is having the forming of your forming the fifth, sixth part of your outer fibrous coat. And what is the importance of it? Yes, we have the extraocular muscle insertion will be here. What is the mean of your all the extraocular muscle? Which is your superior rectus, inferior rectus, medial rectus, lateral rectus, and your superior oblique and your inferior oblique. All the kind of your extraocular muscles will be going to insertion, making the insertion on your scleral layer, on the scleral layer. And now the one important thing which I want to tell you here, related to your sclera, which is more important, the junction of your cornea and the sclera. As you already know, this is the cornea will be the outer, your outer fibrous coat is having the two layer, the cornea and the sclera. So this the cornea and the sclera will be surely meet on a junction. Of course, it will be going to meet at the junction, and this junction will be known as, this meeting junction is known as your limbus. Remember about it. What is the mean of your limbus, guys? What is the mean of your limbus? Yes, your corneal scleral junction. I can say the corneal scleral junction, and junction of the between the cornea and the sclera. It is known as your limbus. It is known as your limbus, right? And what is the important of it? Yes, the conjunctiva is the firmly attached to the limbus, and your conjunctiva, as you already know, the conjunctiva is covering your all the scleral part till the limbus only. Cornea is not involving. Please remember, the cornea is not having, cornea is not covered by your conjunctiva, right? Cornea is not covered by your conjunctiva normally. If I'm talking about the normally here, right? Right, in the diseases part, like in the pterygium, if you say yes, that in the pterygium there will be the degeneration, right? There will be the degeneration of your conjunctiva will be over the your cornea will be seen there, right? But if I'm talking about the normally, yes, the normally the conjunctiva will be till the your limbus only, till the your limbus only, right? If I'm talking about it, let's move forward and remember about the limbus. What is the limbus? It is your junction between the cornea and the sclera. The corneoscleral junction is known as your limbus. Corneoscleral junction is known as your limbus. Let's move forward about the sclera is completed, and moving forward for the next, which is your contain. It is your crystalline lens. Very important structure, right? We have to know about it more in about your crystalline lens, right? As this is the important, that lens is already your transparent. So as you already know, the transparency, it means transparent. The all the transparent structure will be going to participate into your refraction. Okay, so it will be also participating, as I told you, in the cornea also. The cornea will be participating in the your, it will be participating in the your refraction. Also your crystalline lens will be going to participating in the your participating in your refraction. The shape, if I'm talking about, it is a biconvex shape, and this is the crystalline structure, and this is placed between the your iris and the vitreous. As I told you, as I shown you in the starting only, when we was dividing, the our, when we are going to dividing our eyeball, right? So when we was dividing our eyeball into the segments, right, into the segments we was dividing into it. So at the part, at the time of your the division, at the part of your time of the division, I told you about it, right? What I told you, that your crystalline lens will be going to divide it, the crystalline lens only the division part, right, where we make the our we make our imaginary line on between on the lens, right, on the lens. And where was the lens was situated? It will just behind the your iris and anterior to the your vitreous cavity, right? So this is about the your, this is about the your importance about the your lens, right? The next we are talking about the refractive index. As we talked about the refractive index of, as we talked about the refractive index of your cornea, you remember it was the 1.33. So if I'm talking about the crystalline lens, it is your 1.39. The next, the refractive power. As we talked about the refractive power of our eyeball, the refractive power of your total eyeball will be talking about it. If refractive power of your cornea was 44, and the refractive power of your lens will be your 14 diopter to 16 diopter. If I'm talking about the one answer, it will be your 16 diopter should be. Okay, okay, if they're asking only the one answer will be there, right? They are asking you that, just reply the one answer only. Okay, they are marked as answer. What will be the power of your crystalline lens? And they given you the options like that, 14, 16, 18 and 12. So what will be the, your answer should be? Yes, your answer should be 16. Your answer should be 16 will be there, guys. Okay, so this is the importance of your lens. Now talking about the more further for the lens anatomy. So little bit we have to go more into the depth which is related to your lens anatomy. If I'm talking about the lens anatomy, so the lens is having the capsule, right? So what we are having? Yes, we are having a lens capsule. We are having a lens capsule, and this lens capsule is what? Yes, the lens capsule is the outermost layer, which is the outermost layer of the your lens, and it is covered. And if I'm talking about the lens capsule, will be going to thinnest at the posterior pole of it. If I'm going to the posterior part of it, and the importance of the your lens epithelium, as the epithelium you already know, outermost layer. What is the epithelium? Yes, epithelium is your outermost layer. Yes, outermost layer. So your lens epithelium, we have only the single layer on the anterior surface. Yes, our lens is only having the epithelium on the anterior surface of it. We don't have the epithelium on the posterior surface. So remember, the crystalline lens is having the epithelium on the anterior side, and the posterior surface no epithelium, right? So this is all about your crystalline lens. This is all about the importance of your crystalline lens. Let's move forward for the your aqueous humor, oh sorry, vitreous humor. Talking about the vitreous humor, quite easy. Vitreous is a gel-like structure. As I already told you, it is a gel-like structure, and it will be going to filled into your posterior segment, right? The posterior part of your lens, just behind the your lens, we have the posterior segment. So this posterior segment will be filled with your vitreous cavity. If I'm talking about the volume of the vitreous, it will be approximately just 4 cc. Okay, so the total is your 6.5 cc. Out of the 6.5 cc, the total is your 6.5 cc, the eyeball, right? So out of the 6.5, the 4 cc is covered by your vitreous. 4 cc is covered by your vitreous, right? Let's move forward for the next, and it is about your retina. This is about your retina. Very important. Retina is very important structure of your eyeball, right? As per the physiology of your eyeball also, and the anatomy also. So there is we are having the dimensions of the retina also. So on the dimension of the retina, if I'm talking about it, I hope you remember about it when you studied about the glaucoma, or when you studied about the your retinal parts. In the retina, you saw one disc shaped structure is seen near the this is known as your optic disc. If I'm talking about the dimension of the optic disc, it will be your 1.5 mm. 1.5 mm. Also, if I'm talking about the on the other side of it, if I'm talking about your macular lutea, right? So the macular region, so macula will be your having the size of 5.5 mm of the retina. And we have one more important structure which is known as your foveal centralis, the fovea centralis. Yes, it is your again the 1.5 mm, 1.5 mm. So between the distance between your fovea and the optic disc will be your 3 mm. Just remember, distance between your optic disc to the fovea, it is the your 3 mm. So that's why it is known as your double disc diameter. Okay, so this is known as your double disc diameter. It is known as your double disc diameter. If I'm talking about the foveal pit, if I'm talking about the particular foveal pit which you saw, it is just only the 0.35 mm. It is just 0.35 mm. And also we have the more important in the our retina, we have the cells, right? Already the retina, I hope you remember from the retinal chapter, the retina is having the 10 layers. How many layers? 10 layers. Out of this 10 layer, the one layer which is known as your pigmented epithelium layer, this pigment except this pigmented epithelium layer, all other 9 layers is known as your neuroretina, right? Neural retina. Okay, so the all the 10 layers is together is retina, just one is not there, all other 9 is known as your neural retina, because they having the neural cells or the neural perceptions role in the retina, right? So talking about the rods and the cons, as you already know, it is your sensory and the and organ of your vision. Yes, it is making the your visual perception will be there. And please remember, the rods are will be absent into their foveal region. The rods are will be not present into your foveal region. And the ganglionic cell layer, which is your thickest in the macular region. Just remember about it, the all the 10 layers. I hope you remember the name of the all the 10 layers. So your ganglionic cell layer, if I'm talking about your ganglionic cell layer, yes, your ganglionic cell layer will be more thicker in the your macular region. And you already know in the fovea there is a absence of your rod cells, right? So let's move forward for the next thing. It's about the retina, and then we have to talk about the now visual sensation neurons. This is the MCQ, right? Important MCQ. Okay, if I'm talking about it, it's the PYQ also, right? They're asking about the order of the neurons related to the retina, the visual physiology. They are asking you about the visual sensation neurons. So if I'm talking about the neurons, if I'm talking about the neuron, they are asking about the first order neurons. So you have to write the first order neurons are your bipolar cells. What is your first order neuron? Your first order neuron are your bipolar cell. If they are asking you about the second order neuron, the second order neuron is your ganglionic cell layer, the ganglionic cells. And the third order neuron, the third order neuron is your neurons of lateral geniculate body, lateral geniculate body. So remember this, all of these structures just you have to learn by heart, as I already shown you. I hope you remember about it, the all the 10 layers of your retina. So as the light is coming like that, so this visual perception will go again behind like that, right? So as it is going to involvement, so the first it will be in the bipolar cell, then ganglionic cell, then your neurons of your lateral geniculate body, it will be going moving forward. So this will be the order neuron of your visual sensation neurons, right? So the first order neuron bipolar cell, second order neuron ganglionic cell layer, and the third one is your neuron of your lateral geniculate body, is the third neuron, right? Let's move forward for the next anatomically structure, which is your extraocular muscles. So out of this extraocular muscle, it is having the work of it. So before coming to the work, I have to show you the all the extraocular muscles. This is in front of you. This is your image of your eyeball, and this is the all the eyeball is having the extraocular muscles. Totally we have, if I'm talking about it, the totally how much we have the extraocular muscles. Any one of you, how much is the total? How much the total extraocular muscles? Any one of you? In the chat box, I'm waiting for your answers. Yes, 6. 6 is further divided in the 4 are the rectus and the 2 are the obliques will be there. Okay, 2 are the 4 are the rectus and 2 are the obliques will be there, right? So if I'm talking about it one by one about the rectus muscle, so the rectus muscle name is known as the, as this muscles will be going to making the insertion of your on the making the insertion on the your insertion on the your uh, eyeball. This will be the name as the same only. Like the one muscle which is coming from the superior side, and it is going to attach on the superiorly to the your eyeball. It is known as your superior rectus. It is known as your superior rectus. The secondly muscle is coming from the inferior side and going to attach directly to the your eyeball. It is known as your inferior rectus muscle. It is known as your inferior rectus muscle, right? The third muscle, one muscle is coming from your medial side. So the medial side and attached directly to your eyeball. It is known as your medial rectus muscle. It is known as your medial rectus muscle. It is known as your medial rectus muscle. And the fourth muscle, which is coming from your lateral side and directly attaching to your eyeball, it is known as your lateral rectus muscle. Lateral rectus muscle, right? So this is about your all the four rectus muscles: superior rectus, inferior rectus, medial rectus, and the lateral rectus. So this is all the four rectus muscles. And after this rectus muscle, we have the two oblique muscles also. Why the name is the oblique here? Why the name is oblique here? Just a minute. Yeah, sorry for it, right? Let's start. We are talking about their oblique muscles. So this was the four rectus muscle, and now if I'm talking about their oblique muscles, so this oblique muscles, these two oblique muscles are there. And why it is known as your oblique muscle? Because their attachment is the obliquely. So you can see this muscle is coming like that, and they're going to attach to your eyeball into the obliquely. They're going to attach to your eyeball all obliquely. So the one muscle which will be going to attach on the superior side of your eyeball, on the superior side of the eyeball, it is known as your superior oblique. It is known as your superior oblique, right? Superior oblique. And one muscle which is coming obliquely going to attach to your eyeball from the inferior side, this is known as your inferior oblique muscle. This is known as your inferior oblique muscle, right? So we have the six muscles, the six extraocular muscles: superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, and the inferior oblique. I hope you are perfect with this about the extraocular muscles name, right? With the name, I'm going to clear you here only about your nerve supply of it. Quite easy. For the remembering the nerve supply, you have to remember the one mnemonic. What is your mnemonic, guys? I hope who guys are my old students, they remember the mnemonic of it. The mnemonic of it is for your SO4 LR6. SO4 LR6. Just you have to remember this, right? SO4 LR6. What do you mean by this SO4 LR6, right? So your superior oblique SO is supplied by your fourth cranial nerve, and your LR, your lateral rectus, is supplied with your sixth cranial nerve. The rest of it, other four which is left there, what the fourth are left there: superior rectus, inferior rectus, medial rectus, and your inferior oblique. These will be going to supplied by your third nerve. Okay, this will be going to be supplied by your third nerve. Just remember about it. Okay. Okay, just remember with this third nerve, because in the later part when I'm going to talk about the palsies, right, the nerve palsies, okay, then I have to talk about it, the fourth nerve palsy, sixth nerve palsy, and the third cranial nerve palsy. So you have to remember about it, which muscles will be going to supply by this, right? And with this, I hope you remember about it, about the movements of this all the extraocular muscles. So I given a tabular form, I given a tabular form to you, all of you, that this is the muscles functions which is given there. These are all the name of your muscles: medial rectus, lateral rectus, superior rectus, inferior rectus, superior oblique, and inferior oblique. And all the muscles, the functions are written there. The primary action should be there, the secondary action and the tertiary action should be there. I hope you remember about it. I explained very well in the classes. You about the movements of it with the drawing a diagram with you, right? How it is going to diagram is the in the adduction, how it is helping the medial, and in the abduction it will be your lateral rectus. With the lateral rectus, we have in your adduction we have the superior rectus and the inferior rectus also, right? In the abduction we have the superior oblique and inferior oblique, but in the adduction with the medial rectus we have the superior rectus and the inferior rectus. I hope you remember with the mnemonic of your sin, and the sin which is your superiors are intruders, right? The superior are the intruders, okay? And the one is your red, which is your rectus, are your adductors. Rectus are your adductors. So I hope you remember with this all the movements of your extraocular muscles, right? Should we move forward? Okay, let's move forward. For the next is we are moving forward for your glands of eyelids. Now we covered with your eye. Now we are moving forward for the eyelids, and in the eyelids we have to cover about your glands of the eyelid. If I'm talking about the glands of the eyelid, we have the four glands in the eyelid. The first is your gland of meibomium. The second, meibomium gland, you can say second is the gland of G's. Third is your gland of mole. And the fourth, we have the accessory lacrimal glands are available there. Our eyelid, right? So if I'm talking about the meibomium gland, it is situated at the tarsus. It is also known as the tarsus gland, and it is situated at the tarsus only, right, at the tarsus. And it is a modified sebaceous gland. Which type of gland? Yes, it is your modified sebaceous gland, and it is about to 20 to 30 in each lid. It is about the 20 to 30 in the each lid. Okay, so if I'm drawing about it, about the eyelid, so you can see here, this is your eyelid. Okay, we have this eyelashes here, right? So we have the eyelashes here. If I'm drawing about it, okay, so we have, like, it will be on the tarsus, so it will be situated at the tarsus, and the duct of this gland will be going to open at the your lid margin, at the lid margin, right? Just remember about it with the red color I drawn with your meibomian gland. The next gland we have, the next gland is known as your gland of G's, the gland of G's, and this is also your modified sebaceous gland. This is also your modified sebaceous gland, and this will be also where, yes, it will be open into your follicles, right? Which open into the follicle of your eyelashes. So where is the situation of this gland of G's? So every gland is having eyelashes. So in the base of eyelashes, at the base of the eyelashes, we have the gland of G's. At the base of the eyelashes, we have the gland of G's. I hope you remember about it, right? Gland of G's is where the gland of G's will be at the base of eyelashes. The next, we have to talk about the gland of mole, and the gland of mole, if I'm using the different color, the gland of mole, these are the modified sweat gland, right? What is it? It is your modified sweat gland. This, and if I'm talking about it, which is open into the hair follicle. So the duct is open at the lid margin of your meibomian gland also. For the gland of G's also, gland of mole also. So the all are opening at the lid margin only. If I'm talking about the situation of it, so it will be going to situated in between the eyelashes. So between the eyelashes, it is situated like that. Okay. So this is the location of your gland of mole. It is a gland of mole. And the fourth one, which is your accessory lacrimal gland, which is known gland of, which is also known as lacrimal gland of Wolfing, right? Which is known as the lacrimal gland of Wolfing, are present near to the superior border of upper tarsal. So it is, remember, it will be at the superior border of, it is having the superior border of tarsus, upper tarsus, right? So it is situated there, right? So this is all about your glands of eyelid. So if I'm talking about it suddenly in this manner only, we are not going into the deep of this all of it. Just you remember, if the gland of G's will be getting involvement, this is known as your, what is the known as of the disease? If the acute inflammation, guys, reply me in the chat box. You already had all this information with you, right, in your full lectures, right? I hope, right, you had with the any faculty, you did it, you teach with the any faculty. I am not saying like that, right? If you studied ophthalmology from any faculty, they teach you about the gland of G's is having acute inflammation is known as your, let me know in the chat box what it will be going to known as, guys. I'm waiting for your answers. I'm waiting for your answers, guys. What will be your answer? What will be the acute infection of your gland of G's, acute infection of your meibomian gland, and acute infection or the chronic infection of your meibomian gland? The two things. This is the acute infection. This will be also the acute infection, and this will be your chronic granulomatous. Any one of you? Okay. Just remember, this will be known as your stripe. Okay, we'll talk about it also in the brief in the Q&A session about the STI. Also, I will teach you about the STI. I hope you remember this is the acute inflammation of your gland of G's. If I'm talking about is your, the STI is also known as your external hardyolum, right? External hardyolum. Okay, so if I'm talking about the meibomian gland, in the meibomian gland, it is acute infection is known as your internal hardyolum, right? Internal hardyolum, and the chronic inflammation of your meibomian gland is known as your challenge zone. Okay, this is known as the challenge zone. I hope you remember about it. So this is the more importance of their challenge zone. What is the treatment of the challenge zone, guys? Anyone of you can reply me in the comment box. What is the treatment of your challenge zone? What will be your treatment of challenge zone? Reply me in the chat box. I'm waiting for your answers. Incision and drainage. Okay, incision and drainage, or incision and curettage, you can say like that, because we have to do the curate of it, not the draining. We are not draining it, we are curating it. Okay, so incision and curettage. Okay, we'll talk about this incision and curettage also about the challenge zone, in the challenge zone, right? Just remember it. Okay, let's move forward, right? Let's move forward. Now I've given you the two important tables. This is the table number 1. This is the table number 1, which is the more important for your exam point of view. when you're going into the exam. So what they are doing in the more the clinical MCQs, they're just making the in the clinical MCQs, they are giving the key feature, or they are, you can say, they are giving you the clinical key points like that, the sudden painless loss of vision. So if they are giving you the clinical feature, or in the symptoms, or in the sign, in the symptoms they make that there is a sudden painless loss of vision. Painless, please remember the word I mean here. The word is the main here, it is your painless. The word is here, main is your painless. So if they are asking you about the painless vision, right, painless vision loss, so in the painless, what will be your answer? Yes, there will be the central retinal artery occlusion, which is known as your CRAO. You know about it, right? Also, there will be the massive Vitus hemorrhage can be there, right? Or maybe retinal detachment involving the macular area. And the last one, which is your ischemic central retinal venous occlusion, right? It will be your ischemic central retinal venous occlusion. Okay, so it is your CR VO. It is your CRVO. But which one? Ischemic one. Okay. Please remember the ischemic one, CRVO. So this is all is having, or you can just remember with the CRVO. So it will be quite easy for you. Okay. Just go with your CRVO. Okay. CRAO, central retinal artery occlusion, central retinal venous occlusion. The both are having the sudden painless loss of vision and massive vital hemorrhages, and the retinal detachment involving your macular area will be having the painless. Please remember the painless loss of vision. Painless loss of vision. Okay. So this is the important table number 1. So out of this, if they given you the in the MCQ, the clinically they mentioned that there is a sudden painless loss of vision. They mentioned the sudden painless loss of vision. So your mind is saying yes. Out of this four will be the your diagnosis. So out of this four, which is given in the your MCQ as the option, so just you have to mark that. You have to mark that. Okay. Next, the table number 2 I given you here, and this table number 2 is having the sudden painful loss of vision. Sudden painful loss of vision. It means in this condition, the patient is will be mentioned as in the clinical MCQ. There will be the painful. The patient is having the more pain, and now the vision loss is there. Okay, loss of vision. So the first is your acute congestive glaucoma will be there, right? Or you can say the angle closer glaucoma. Also, it can be known as your angle closer glaucoma, ACG, right? It is known as your angle closer glaucoma. The second one will be your acute iridocyclitis. And now you can see this is the, maybe there is some chemical injury. Maybe some chemical is splashed into the eye of the patient. So there's some chemical injury, or maybe any kind of mechanical injury also. Please remember. So the mechanical injury, the patient will be facing what? The sudden painful loss of vision. Sudden painful loss of the vision. So this two tables will be going to making your 1 mark surely. Okay, 1 mark out of this two table. Okay, so because always and always when they are giving you the big clinical scenario of ophthalmology, they always and always mark, or always they will make a question depending on this painless loss of vision or the painful loss of vision. So I try to make it as a tabular form of it, that which is having the painful and which is having the painless, okay, loss of vision, right? So you have to remember about it. Just remember it is a sudden. Please remember I made here the sudden, because all of many of you are thinking that, sir, there is a painless loss of vision in the cataract also, but it is not the sudden, it is a gradual. Okay, slowly it will be going to the loss of vision will be there. But if I'm talking about the sudden one will be your central retinal artery occlusion, central venous occlusion, vital hemorrhages, or maybe the retinal detachment will be there, right? So this is all the important you have to remember about it. You have to remember about it. Now moving forward for the some ocular examination techniques, right? So which is all the instrument which is used in the your ophthalmology clinic to making the diagnosis or the making some examination on the patient in the ophthalmology clinic. We are using the some instruments. So one by one we go with the all the name the instrument, because in the FMGE exam sometime, or in the NEET PG exam also, they are sometimes asking what they are giving the such images, and they are asking the name of this instrument or the use of this instrument, right? So the one by one, just go with me. We'll cover up all instruments in the fast and quick manner, right? So is the session is going good, guys? Let me know in the comment box. Let me know in the chat box, guys. It's going perfectly. All are here, guys. It's going perfect, right? Anything is there? Did you understand till now, which we already covered all the topics? Reply me in the chat box, guys. I'm waiting for your replies. I'm waiting for your good, perfect, right? Okay, good, right. Very good. Okay, let's move forward. Okay, let's move forward. Okay, so now we have to talk about the ocular examination. As I have to talk about the ocular examinations, so in this examinations, we have to talk about the all the instrument, and I'm starting with the first of all your instrument, which is known as your slit lamp by microscope. I hope many of you are using the specs, and you also visited your ophthalmology clinic to go with your regular checkups to your ophthalmologist, right? And you saw this particular instruments. What is the happening in this instrument? You can see here in this instrument, this is the patient side, this is the patient side, and this will be your doctor side, and the patient should be having this chin rest. Okay, chin rest here, and that should be your headrest of the patient, and this will be your eyepiece. Okay, from where the doctor will be going to see, this will be the dial of it. The doctor will be going to set the light which is coming from it, and this is your light source. Okay, this is your light source, where will be the light will be falling from it. Okay, so the patient will be sitting in front of the doctor, and the doctor will be going to evaluate from here. Just please remember, from the slit lamp by microscope, we can evaluate only the anterior segment. What we can evaluate? We can evaluate the anterior segment just with the only slit lamp by microscope. Please remember with me. Now, this is a question to you. What the structures we can see in the anterior segment? Just let me know first. I'm waiting for your comments, guys. I need your reply to make this session interactive. Okay, I want to know that how much the knowledge you have remembered, or you have related to the ophthalmology, or you revise your subject well or not. Tell me, what are the structures I can see by the slit lamp by microscope, as I'm evaluating only the anterior segment through this. I'm waiting for your answers, guys. Okay, anyone of you? Okay, first of all, eyelid. Agree, eyelids will be there. Okay, eyelashes will be very good. Okay, then lens, very good. Lens will be visible there. After the lens, there will be the cornea. After the cornea, there will be the iris, very good. Iris can be seen there. What about other? What about other? Sclera, conjunctiva. Very good. And just remember about it. This is all in your anterior segment, which you can see from it. Just one thing, which from the posterior segment, just 1/3 of anterior vitreous. Okay, what I can see, just anterior 1/3, just the small amount which is just behind the lens. Okay, so just behind the lens we have the vitreous, so just 1/3 part, which is the anterior most, right? Just behind the lens we have the structure of the vitreous. We can see that also by this slit lamp by microscope. So this is the use of slit lamp by microscope. So when you are visiting to the doctors, the doctor will be going to sit you on this particular instrument, which is known as the slit lamp by microscope, and you had the examination on it, right? At the examination of it. And after doing it, after the doing this your ocular examinations on it, just we had with the anterior segment with this. But if I want to see the posterior segment with the slit lamp by microscope only, if I want to see the posterior segment with the slit lamp by microscope, so I have to use your slit lamp by microscope with the 90 diopter of the lens. What I will use? I will use the slit lamp by microscope. Please remember, this is your slit lamp by microscope. And with this your slit lamp by microscope, what? With the slit lamp by microscope, we'll use the 90 diopter lens. We'll use the 90 diopter lens, so it will be going to see your posterior segment. And you can see here what I am evaluating. Here we are evaluating the posterior segment. How with the posterior segment? This is your slit lamp by microscope. This is your slit lamp by microscope. So you can see from the eyepiece, the doctor is looking into it. This is the eyepiece of the microscope, right? By microscope, and you can see this is your dial. This is your dial. You can see the doctor is rotating it through this other hand, right? And it is having, on the other hand, it is having a lens here, And what is the power of this lens? Anyone of you can tell me? This is the 90 diopter lens. How is the power? Is the power of this lens is your 90 diopter lens. And as it is, she is using the 90 diopter of the lens. You can see this is the chin rest. The patient is resting the chin here. This is your headrest. This is your headrest, and this is the light source. The light is coming like that. Okay, this is the light source of the word slit lamp by microscope. Just remember, as she is using the 90 diopter of the lens in the hand. So what we are evaluating? We are evaluating the posterior segment. In the posterior segment, yes, in the retina, we are seeing the retina. We are seeing the fundus. Okay, we are seeing the fundus, or we are seeing the, you can say the fundus also, and you can say like that we can see the vitreous also. If the vitreous hemorrhage or whatever is there, so vitreous is also seen by this slit lamp by microscope plus 90 diopter lens. Please remember, plus 90 diopter lens should be used with this slit lamp by microscope, right? So this was your eye evaluation instrument. Okay, after the slit lamp by microscope, now I'm moving forward for the next instrument, which is known as your tonometer. What it is known as? Yes, it is known as your tonometer. And the use of tonometer, yet what we are the use of the tonometer? The tonometer is for the evaluating or the measurement of your intraocular pressure. Now understand the thing, what do you mean by the intraocular pressure? As the word is saying intra, it means the inside, ocular, it means the eyeball. So inside the eyeball we have a pressure which is known as your intraocular pressure, which is known as your intraocular pressure. So inside the eye we have a pressure. As you already know, what is the mean of blood pressure? What is the mean of your blood pressure? The blood which is flowing inside your vessels, it will be making a pressure on it, on the pressure of the walls of it. The same thing in our eye, we have the contains in the eye, like we have the vitreous, we have the aqueous. So this aqueous and vitreous will be also, this fluids will be also making the pressure on the walls of your eyeball. It is known as your intraocular pressure. It is known as your intraocular pressure. So for measuring this intraocular pressure, we have the various type of instrument which is known as your tonometer. And out of this tonometer, I want to show you the Shizot's tonometer. Right, nowadays it is not used because it is not the good to use it, because it is you can see this is going to touch on the cornea. We have to touch the cornea of the patients, and we have to making the pressurize on it. So this is the old type, and it will be going to show you the, by this dial, it will be going to show you the measurement of it. So you can see here, by this the patient is having to put it this, so it's showing you the Shizot is going to see your intraocular pressure. Intraocular pressure is seen to you, right? So this is your Shizot's tonometer. Out of this tonometer, if I'm talking about it, which is the best tonometer, yes, the best out of this best tonometer is your Goldman application tonometer. What is the name of it? Yes, it is the name of your Goldman application tonometer. This is your Goldman application tonometer. What is it? It is the eyepiece of it. This is the eyepiece of it. It is having the attachment site. This is your attachment site. Okay. And after this attachment site, we have one dial here. And now you can understand, sir, what is the mean of attachment site? Yes, this your Goldman application tonometer will not use individually. ये individually use नहीं होता है. So how to use this? Yes, we have to attach this slit lamp, attached to this Goldman application tonometer with the slit lamp by microscope. You can see here, it is attached to the slit lamp by microscope, and we have to use the light source of this Goldman application tonometer, and we have to put the cobalt blue filter. Which filter? Cobalt blue filter. So it is a kind of filters which is available in the slit lamp by microscope only. So the light which is coming there, we put in a filter in the source of the light. So this light will be converted into the blue color, right? Blue color. And now what we will do, this eyepiece will be going to touch on the patient's cornea. And after the touching to the patient's cornea, I have to see in the slit lamp by microscope. So they will be seen the two halves of it. They will be seen like this, two halves of it, maybe like that, or maybe it will be like that. Okay, it will be like that above. So, right, so what I have to do, I have to rotate this dial, and I have to make this both of the halves of it into the together like that. So you can see in this image, this is the perfect image of it. You can see this is the making the whole full attachment of this both of the halves or round of the halves of it. So when this will be going to touch, right, you can see it is the making the both like same only. Like when it is going to make, we have to say the patient now he or she can remove their eye from this Goldman application tonometer, and now I have to see the values on this dial. On the dials there is a the values are written there, so I have to see at which level or at which value this will be going to see here. So this is known as your Goldman application tonometer. This is the best tonometer as is known as the Goldman application. So this will be their gold standard. What does that mean? It is a gold standard. It means this is giving the best and correct values also. Also, we have the different type of tonometers also, which is your rebound tonometer, tonopan is there, self-use tonometers are also there, non-contact tonometers are also there. Many kind of the tonometers are there, but these two are the important, right? I hope you know about the all others also. Just remember about this two. This is the more important. Okay, let's move for the next investigation. The next investigation is known as your gonioscopy. What is the mean of the gonioscopy? From the gonioscopy, we are going to see the your angle of anterior chamber. Yes, what we have to see? We have to see through this gonioscopy. We have to see the angle of anterior chamber. And you already know why I have to see the angle of anterior chamber. As you already know, the aqueous will be getting outflow from their angle of anterior chamber. Right? Yes, your aqueous will be getting outflow. The aqueous will be made. We'll talk about the aqueous outflow also. I will show you in the glaucoma disease. Aqueous outflow के बारे में हम बात करेंगे. So as we have to see the in the diagnostic or in the diagnosis of the glaucoma, we have to do the gonioscopy also. What is we have to do the gonioscopy? Yes, this is your gonioscopy. This is your 3 mirror. And this will be your 4 mirror. Okay, we have the two type of the gonioscopy. One we have the 3 mirror, the second one is your 4 mirror. So how you can be differentiated is 3 mirror is not having any stick will be there, the 4 mirror will be having a handle on it. So you can see here which one is used by this doctor. Yes, this is used by the 3 mirror. Okay, this is used by the 3 mirror. Okay, this is used by the 3 mirror. Okay, so this is used with the slit lamp microscope. Again, this is used with the slit lamp microscope, and we are getting a view of your angle of anterior chamber. And out of doing this gonioscopy only, we can say the angle of anterior chamber is open or closed. Okay, so as on the depending on this gonioscopy only, we can do the identification or the diagnosis of it. If angle of anterior chamber is open and your intraocular pressure is rising there, it will be in your open angle glaucoma. If its angle is getting closed and your intraocular pressure is increasing and making your visual field disturbance, it will be your closed angle, or you can say the closed angle glaucoma, you can say, right? And the open angle and the closed angle, right? So this is about your angle about the related to the glaucoma. We are doing the gonioscopy, right? What is the we are evaluating? We are evaluating the angle of anterior chamber. Through this, what we are evaluating? Yes, we are evaluating the angle of anterior chamber. Just remember again the two parts of it: the 3 mirror and the 4 mirror. Okay, any difference will be getting from it? अगर ऐसा पूछा जाए, if the main difference they are asking you what is the difference with the 3 mirror and 4 mirror, there is no big difference between the 3 mirror. We have to use this both of it to the doing the evaluation of it. Just remember about it. Okay, okay, let's move forward. Let's move forward for the next investigation of it. So this was the gonioscopy. This was about the your gonioscopy. Let's move for the next one, and this next one is known as your direct ophthalmoscope. The next one is known as your direct ophthalmoscope. I hope you remember with this ophthalmoscope what we are doing. We are doing the evaluation of your posterior segment, or you can say the fundoscope also, right? This is the fundoscopy also, because we have to see from it what we're gonna see the posterior segment. We have to see the fundus of it. Now, how to remember this? Because it is similarly looking to your retinoscope also. We'll talk about the retinoscope in the chapter of refraction. In the chapter of the refraction, so you can remember this is a handy instrument. The doctor will use this hand instrument into using with the hand, and the doctor will be going to evaluate the eye of the patient, and through this there will be the light will be going to pass. This is the light source of it. You can see there will be the light will be getting passed. This is the light source of it, and this will be the eyepiece. Okay, from the eyepiece we have to see. Okay, we have to see, the doctor will be going to see. So the light source will be going to pass the light, and the eye from the eyepiece we have to see. Just remember about it. We have the dial on the side of this body. This is the dial of it. Okay, this is the dial of your direct ophthalmoscope will be on the side of the body, right? So this is the having the what we are seeing. Yes, we are seeing from this direct ophthalmoscope we have to see the fundus, and it is having the more magnification. Just remember about it. It is having the more magnification. How much the magnification will be there? How much? Anyone of you can tell me? How much will be the more magnification? Yes, it will be having the 15 times more magnification. Okay. Out of this 15 times more magnification, that's why only what we can see through this, we can see the optic disc through this optic disc, and we can see the fovea, we can see the macula. We cannot see the peripheral of the retinal part, we cannot see from this particular direct ophthalmoscope instrument, right? So that's why we have to just use this in the case when we want to see the optic disc or just the fovea and the macula, right? We cannot see the periphery of the retina through this direct ophthalmoscope. So for seeing this direct ophthalmoscope is not used in the hazy media also, not used in hazy media. Okay, what do you mean by the hazy media, guys? The hazy media, it means when the media is not the clear, right? When the media is not the clear, if I'm talking about the refractive media, right? Refractive media, we will talk about the refractive media. I will give you the mnemonic of it also. So this media, it means from where the light will be going to pass in through your structures to do the refraction of it. So this is known as your refractive media, right? So that if the media is hazy, it means the patient is having the cataract or the patient is having the corneal ulcer. Okay, so in this condition, this instrument will be not useful to see the fundus of it, right? So then what we have to do? Yes, we have to use the indirect ophthalmoscope. We have to use the indirect ophthalmoscope. Again, this is instrument is also used for the your posterior segment, or the you can see the fundus by this. And for the using of it, this is a different kind of instrument that your direct ophthalmoscope was your handy instrument, like a pen. I'm showing you like that. This will be like that, and we are using like that, and it will be handy instrument. But if I'm talking about this instrument, this will be not their handy instrument. It will be your little complicated instrument, and this will be put it by the doctor. The doctor should have to wear this instrument on the head. You can see here the doctor is wearing this instrument on the head, and through this there will be the light will be going to pass through this instrument. The light will be going to pass through it, and this light will be going to pass through it, and the doctor will be holding a lens here, and this lens is having your 20 diopter lens. How much the power of this lens? The lens in the your indirect ophthalmoscope, the lens is used, it is your 20 diopter lens. It is your 20 diopter lens, right? And this 20 diopter lens will be what will be going to cause, right? It will be giving us the clarification of the your fundus. And please remember, out of this indirect ophthalmoscope, what is the importance of it? It is just making the 3 to 5 time of the magnification. Okay, so that's why through this we can see the optic disc, we can see the macula, we can see the fovea, we can see the periphery of the retina. Okay, we can see everything, right? All the fundus will be seen by this, all the full fundus will be going to seen by this particular instrument, through this particular instrument, right? So this is about your indirect ophthalmoscope. This is about your indirect ophthalmoscope, right? So I hope you understand about it. Just remember which if I want to see the posterior segment, I can see from the three instrument. What are those three instruments? The first instrument is your slit lamp biomicroscope with the 90 diopter of the lens. The second one is your direct ophthalmoscope. The third one is your indirect ophthalmoscope. The next I have the perimetry. Next we have the perimetry. And what is the main use of this perimetry, guys? Please understand, through the perimetry we are going to get the visual axis. Okay, what do you mean by the visual axis? Yes, we have to see how much the visual field. Okay, what we can say, visual field will be getting by this. Okay, by this visual field, what will be getting by this visual field when the patient will be going to do. So what is the mean of your visual field? As I'm seeing in front of you, without moving my neck, without moving my eyeballs, how much the things I can see, how much the view I can see into it. This is known as the my visual field, right? So as this is the computerized visual field, so the patient, you can see here, the patient will be going to sit here, and the doctor will be going to assist this patient that they have to keep the eyeball into the aligned movement. They don't have to move their eyeballs, right, and not move their neck also, and they have to sit like that. And there they will be going to get the reports of the perimetry. I will show you the perimetry reports also. So what will be the normal visual axis or the visual field of it? On the superior side, we are having the 50 degree of it. Like what they mean? If I'm not moving my neck and not moving my eyeballs. What till how much degrees I can see on the superior side? Only the 50 degrees, and this is the minimal. Okay, you can see the minimal. Okay, the minimal visual field we have on the superior side. Although on the nasal side, if I'm talking about on the nasal side, we can see on the 60 degrees. On the inferior side, it will be the more the 70 degrees, and the most important, which is the maximum we can see on the temporal side, which is like that. So in the temporal side, like I'm sitting like here, so this on the temporal side, I can see the, without moving my eyeball and without moving my neck, I can see till the 90 to 110 degrees. What I can see? I can see the 90 to 110 degrees, and it is the maximum. And the maximum visual field will be on your temporal side. So the minimum visual field will be on the superior side, the 50 degree, and the maximum visual field will be on the 92, on the temporal side, 90 to 110 degree. Please remember this, both of important points, right? So this is about your perimetry reports. This is about your perimetry reports. We are getting the visual field. After that, we have the your OCT. What is the OCT? Yes, this is your optical coherence tomography. So from this tomography, we have to get the related to the all the retinal layers. So this is the all the for the retina. Okay, this is the test of your retina, and what we can get, we are getting the layers of retina. Okay, we are going to see the layers of the retina. So you can see this is the computerized structure. So the doctor will be going to assisting this patient, and we will get the through this we are getting the retinal part. We are getting the retinal part, right? So you can see through the screen this all the layers, this yellow green color layers which is shown on it. The computerized, this is your retinal layers. This is your all the about the retinal layers, right? The next, now we are moving further for the next chapter. So the anatomy is finished, physiology is finished for about it. We finished with the your ocular instruments also. Now we are moving forward for the optics and the refraction part of the chapter. Just let me know once in the chat box. Did you understand till here? Any confusion is there? Just let me know in the comment box. So I will repeat the topic. If you have any confusion, let me know. And just let me know about the speed also. Again, I'm asking you about the speed. If you want to increase, I can increase more also. Okay. If you want to decrease, I can decrease also. Just let me know in the chat box once. All are here, guys? Good going, right? The speed is okay? Okay. Are you understanding the everything? If anyone is having any query, just let me know in the chat box. Okay. Let me know in the chat box. Okay. Okay. Let's move forward now. For the next is your optics and the refraction. This is also the important chapter of your ophthalmology. And through the starting before your optics and the refraction, first of all, I have to talk about the refraction power of the eyeball. So the total eyeball is having the power of 60 diopter. If I'm talking about the range, so the range is from the 58 to 60 diopter. Okay, so the 58 to 60 diopter. If they're asking you single short answer, it will be the 60 diopter. The cornea, of course, the cornea is having the 44 diopter. It is having the range of 42 to 46 diopter. Okay, 46 diopters will be there. And the next we have the lens. The lens will be having the 14 to 16 diopter. The 14 to 16 diopter should be the range of it. So this will be the all about your powers of the refractive powers of your eyeball. The refractive powers of your eyeball. So revise with me in the class only. Revise with me now only. What are your refractive powers? Tell me now first. Tell me what is your all the refractive powers. We have the refractive power of your total eyeball is your 58 to 60. Or if I'm talking about the one answer, it will be your 60 diopter. And if I'm talking about the cornea, cornea will be your 44. The range will be off from the your 42 to 46 diopter. And if I'm talking about the your lens, the lens will be having the your, just a minute, guys. Sorry for this disturbance. Just a minute. Yes. So our lens is having the what? Okay. So our lens is having the what? Our lens is having for the 16 diopter of the 16 diopter of it. Okay. So this is about the your important refractive powers values which you have to remember here, right? Next we have the refractive index or the refractive media of the eyes. As I already told you, we have to remember is this. I made a list of this all the here. So you can remember here the refractive indexes and the media of the different eyes. Like our cornea is having the 1.37, our aqueous humor is having the 1.33, and our crystalline lens is having 1.39, and the vitreous is having the 1.33 as the same only, right? As the same only. And also I have to make one more question here. What is this? This is your refractive media. This is your refractive media. What is the meaning of, guys, your refractive media? Your refractive media is that when your light will be going to pass through your eye till reach to the retina, it will have to pass through the several structures. This all structures are known as your refractive media. And what is the mnemonic of it? Yes, the mnemonic of it is your CALB. What is the meaning of your? Yes, the mnemonic of your clav, right? And write a arrow here like that. Okay, so the light will be going to pass through like that clav. The C is your cornea, the A is your aqueous humor, L is your lens, and your V is your vitreous, right? So what is the mean of your clav? What is the full form of your clav, guys? Yes, your clav will be your C is cornea, A is aqueous humor, L is your lens, and V is your vitreous. V is what? V is your vitreous. Okay, so this is all the part of refractive media. Okay, so you have to remember, in the part of refraction we have to talk about the refractive media also. So what is the mean of refractive media? Yes, the light should pass through this all the structure to reach the retina. So light को retina तक पहुंचने के लिए which structures they have to pass? They have to pass this all the structure. They have to pass through this all the structures, and this structure is known as your refractive media. This structure is known as your refractive media, right? So these structures are known as your refractive media, right? Should we move forward? Right? Should we move forward for it? Okay, so the refractive media is clear, and refractive indexes is also clear. About the values of your refractive media and the refractive index, I think it's clear to you, right? Just remember about it. If I'm talking about the refraction, so from the childhood, if the childhood patient is coming to, or the newborn patient is coming to you at the birth, the patient is having the eye hypermetropic. How much? +2 to +3 diopter. The patient is having the hypermetropia. Child को क्या होता है? Child is having the hypermetropia. Okay, the child is having the hypermetropic eye. Okay. Now moving forward one by one with all the refraction errors. Okay, so we have to talk about all the refractive errors of it, and starting with the refractive errors. Before the starting of your refractive errors, the first of all I have to talk about the first error, which is known as your hypermetropia. I'm starting with the first important refractive error, which is known as your hypermetropia. Guys, I hope you remember with the hypermetropia, and what is happening in this hypermetropia I can explain you in a quite easy manner to your understanding of you. I hope in the brief you understand. Just I'm quickly revising you the hypermetropia. These parallel rays are coming from the outside, and out of this parallel rays, this will be going to make the conversion of it, as from the passing from the cornea, then your lens, it is having the conversion power. So after the making of the conversion, it should be converts at the point of retina. Normally it should be focus point at the retina. It should be the focus point at the retina, the normally. But now what will be happen to the hypermetropia? In the hypermetropia, there is a decrease in the total eye power. Okay, so the total eye power is getting decreased. So as the total eye power is decreased, so now what will happen? It cannot make the conversion more, and as it is not make the conversion more, what will be happen? This view, which is the focus point, this focus point will be falling behind the retina. This F1, this focus point will be behind the retina. This focus point will be where it will be going to make behind the retina. This focus will be where this focus point will be going to make behind the retina. As it is make behind the retina, as it will be behind the retina, so the patient cannot see the clearly. The patient cannot see the clearly the things. And the important thing is here, this is known as the long sightedness. Now this is the confusing for you, and the examiner is always and always asking you the tricky things. You already know, right? The examiners want to confuse you in the exam. So what do you mean by the long sightedness? Are you thinking the patient cannot see the far objects? No, it's absolutely wrong. It's a misnomer. The patient is facing the problem into into near vision. Okay, the patient is having the where? The patient is having the problem into the hypermetropia. The patient is having the near vision. What about the far vision? The far vision is okay. Okay, the patient is facing the problem into the just near vision. Okay, so the patient's near vision will be not the clear. The patient's near vision will be not the clear. And why the name is given the long sightedness? Because the normal focus point is the f is here. It is falling more behind this focus point. So it is making more longer the refraction. Okay, so it is making the more longer, prolong the time and the longer, so making the conversion of it. So that's why this is known as the long sightedness. Please remember, don't confuse with it. The examiner surely going to confuse you in this long sightedness. So the hypermetropia is known as your long sightedness. Now if I'm talking about the treatment part of it, about the simple hypermetropia, so please remember, in the hypermetropia we are using the convex lens. Okay, what we are using? We are using the convex lens. Also, you can say the plus lens. And why I'm using the plus lens, guys, as you already understand, the total eye volume, or you can say the total eye power is getting decreased. Okay, so eye power is decreased. Like I'm giving you example, like total eye power is 60, so it's decreased, right? It's decreased how much? It's decreased to the maybe the 55 or 54, like that. Okay, so we have to make it normal. Okay, make this normal, so we have to add on it, right? So the making this add on, that's why we have to use the plus lenses here. What we have to use? We have to use the plus lenses in this condition. So that's why this is the treatment part. If I'm talking about the hypermetropia, this is the hypermetropia treatment. What is the hypermetropia treatment? Use the convex lens or use the plus lens. Okay, this is your plus lens. Okay, and in the hypermetropia we are using the convex and the plus lens in a spherical form. Spherical form. What do you mean by your spherical form? Please remember about it. The spherical, it means that your eye or the lens will be having the two axes. In the spherical, we have like that plus two spherical, plus two diopter sphericals. So it will be having on the horizontal manner also the plus two power, and in the vertical manner is also having the plus two power, right? So we are using what? Convex or the plus lens in a spherical form in the hypermetropia. So this is about the hypermetropia. If I'm talking about the hypermetropia, so the more common the types of the hypermetropia are the two types. What are the two types? The first one is your axial hypermetropia. The second one is your the axial hypermetropia. The second one is your curvatural hypermetropia. Just remember with this axial hypermetropia, yes, we talked about the axial length. What was your axial length, which is your antero-posterior length? It was your 24 mm normally, right? 24 mm normally. So if I'm drawing a diagram here, so you can understand this is the rays which are passing here. This is your cornea, and after the cornea, this will be your eye. Okay. So the normally, what will be happening? The normally your rays will be going to participate, doing the conversion and making the perception where the making the perception out of there on the retina on the focus point f. So if there is a decrease in the your axial length, so if your length is decreasing, so what is happening in this eye? If the eye length is decreased, now I'm drawing with the different colors so you can understand the thing. So if your axial length of eye is not now the 24, it is just left with the 22. I'm giving you as just example of it, so you can understand the focus point is made on the same point only, but now the eye size is decreases, axial length is decreases. So this is known as your axial hypermetropia. This is known as your axial hypermetropia. So what is happened? There is your decreasing in your axial length. Okay, axial length is going to decrease here. So due to the decreasing in the your axial length, there will be the seen is the hypermetropia will be going to seen. Hypermetropia will be going to see. The secondly, in the curvatural hypermetropia, yes, there will be decreasing in the curvature also. In the decreasing in the curvature, what do you mean? As we have the cornea is having a perfect curvature like that, if the flattening of the cornea is seen like that, if the flattening of the cornea is seen, the curvature is going to decrease. So it will be going to make the curvatural hypermetropia. It will be going to make your curvatural hypermetropia. So what is the main two types of your hypermetropia is there? The one is your axial hypermetropia. The second one is your curvatural hypermetropia, right? So the two hypermetropias are seen here, right? Which are axial and the curvatural, right? I hope you remember about it. So this is about your hypermetropia. Now we are moving forward for the next one, which is your myopia. And myopia is also known as your short sightedness. Now again the misnomer and the making confusing to you, the name is given the short sightedness. So what do you are thinking? The short sightedness means the near vision is affected? No, here far vision will be going to affect it. Your far vision will be affected. Okay, so your far vision will be going to affected in this condition, in the myopia. Then why the name is given the short sightedness? So you can see here, this is the parallel rays which is coming from the outside. After the making the conversion of it, they have to make the focus point on the retina, this f, but because of it, the making more conversion, it is making a focus point in front of retina or just before the retina only. Okay, in the hypermetropia, it is behind the retina. It was the behind the retina. If I'm talking about the myopia, it is just in front of the retina, or you can say just before the retina only, they make the perception focus point. So due to this, what is happening? Due to this, what is happening? This is your focus one point, right? So due to this, what is happening? This is known as, this is making a shorter. Yes, it is making a shorter. Yes, in the that there was the longer from the retina, and it is just shorter from the retina. So that is known as your short sightedness. That's why this is known as your short sightedness. So the patient is having the far vision problem. If I'm talking about it, why it is making more conversion before the retina only? Because there is an increasing into your total eye power. Okay, there's a total eye power is getting increased. So if I'm talking about it, about the myopia treatment, in the myopia treatment, we will use the your concave lenses, which is your minus lens, and in your spherical form also. Okay, use in a spherical form only, right? Your concave, which is your minus lens, which is used in the spherical form. Again, the same thing. Minus lens is the like a spherical form I'm giving you. Like -3 will be on your vertical and the -3 will be on your horizontal. The both axes will be in the spherical will be going to same. So the concave, the minus. So for remembering it, just remember with the first word, the myopia is having the letter M, and the minus lens will be used in it. Minus lens will be going to used in it, right? This is about the myopia. If I'm talking about the types of the myopia, so there is a three type of the myopias are going to seen here. The first one is your axial myopia. If I'm talking about the axial myopia, yes, what will be happen in this condition? If I'm just comparing, this is just opposite to your hypermetropia, like that. Okay, so if I'm talking about it, so what is happening in this? In this axial in the axial myopia, there is a increasing in your axial length. Okay, there is increasing in your axial length. As the axial length will be going to increase, so this as the eye length will be going to increase, yes, so this view will be making on the same side only. Like I'm giving you example, again I'm drawing you the same diagram. This three waves are coming, light waves are coming from the outer side of your eyeball, and this is your eyeball. This will be going to make on the your retina. Okay, this is your perception will be going to making on the retina. But now if I'm going to give you that this the axial length is increasing, so the length of your eye is increased. So now the view or the perception will be making on the same point only, but it is remain before the retina only because increasing in the axial length. So this is known as your axial myopia. The second is your curvatural myopia. If I'm talking about the curvatural myopia, this is thing here also the increasing in your curvature. Okay, if the increasing in the curvature, yes, if the your curvature will be going to more, like I'm giving you example of your keratoconus. Okay, so in the keratoconus, what will be happening? In the keratoconus, your cornea will be going to protrude. Yes, your cornea will be going to making the protrusion of it, and as the protrusion will be there of your cornea, the cornea will be getting protruded. So what will be happening? Due to this? Due to corneal protrusion, there will be the seen the myopia will be going to see. Yes, you already know about this myopia will be going to seen to you. So this is about the your curvatural myopia. And the last one, which is known as your pathological, which is known as the degenerative type of the pathological, also known as the degenerative type of the myopia. And it will be going to see in a pathologies where what will be happen, where will be the tumors will be going to stretching the your, when the tumors or maybe any other pathology will be going to stretching the your posterior segment, the stretching of posterior segment. If the stretching of the posterior segment is seen there, so due to this there will be the stretching. There will be the scene of your myopia will be going to see, and this is known as your pathological. It is known as your what? It is going to known as your pathological degenerative myopia. Pathological degenerative myopia will be known as. Okay, so this is about your myopia. This is about your myopia. I hope you remember about this myopia. Okay, so now as you understand about the hypermetropia, you understand about the myopia. Now we have to talk about the astigmatism. What we have to talk about the next is your astigmatism. What is happening in the astigmatism? Just understand the thing. In the normal eye, we have this normal eye, we have the vertical axis and the horizontal axis in the normal. So vertical and the horizontal will be equal. Normal. In the normally, if I'm asking. And if I'm talking about the astigmatism, so what is happening in the astigmatism? Please understand the thing. There will be the vertical will be increasing, right? Or maybe your horizontal axis will be going to increase. Okay, so there will be the disturbance between your vertical and horizontal. In this, vertical and horizontal will be not the same in the eye. So if vertical and horizontal will be not the same, so what will be happen? Now what will be happen? The vertical axis will be also making a point, which is the focal point, and the other one, the second one, the horizontal axis will be, vertical axis is making a different point, and the horizontal axis will be going to making the different point. So you can see this cornea with the astigmatism, you can see this light rays is passing. So it is making the focus point F1 is here, and one focus point is on the retina, which is F2 is here. So there is a two focus point, the two focal point in the scene. In any condition, it is known as your astigmatism. What is this known as? It is known as astigmatism. Did you understand about the astigmatism? Why the astigmatism? Because our eye is having what? Our eye is having the vertical and horizontal diameters. Okay, so the vertical axis and the horizontal axis should be same. Okay, normally we have the same, but due to some conditions, there will be the difference between this your vertical and horizontal diameters, if it's seen is there. So if vertical and horizontal, if your vertical and horizontal disturbance will be seen, if your vertical and horizontal disturbance will be going to seen in this conditions, so there will be the, this is known as our astigmatism, right? And due to this astigmatism, there will be two focus point will be seen there. So there is the two focus point will be there. If I'm talking about in this astigmatism, what will be happen? There will be the, is there any is there will be the your far sightedness or the short sightedness will be there? No, it is depending on the type of the further refractive errors. Just remember, with the astigmatism, the patient will be facing the blurring of vision. Blurring of vision. Okay, we'll talk about it the further in about the depth of your all the different type of your astigmatism, like simple myopic astigmatism, simple hypermetropic astigmatism, compound hypermetropic, compound myopic, and the mixed, right? We'll talk about it. Just remember, in this patient is facing the blurring of the vision will be seen there, right? So talking about now the types of the astigmatism. If I'm talking about the types of the astigmatism, we have the three type of it. Okay, we have the three type of it. If I'm talking about this, all the three, in the three also we have the subdivision also. Okay, the subdivision is known as, the first one is known as your simple myopic, the simple myopic astigmatism. Now what will be happening in this condition? Please understand the thing. Also, as I told you, the focus point will be what? Two, the focus point 1 and the focus point 2. The one focus point, the F1, there will be the two focus point, as I already told you. There will be the two focus point will be there, F1 and F2 will be there. Just out of this two focus point, one will be normal and other will be myopic. Okay, so what will be happening in this condition? Please understand the thing. The one this focus point will be on your retina, and the second focus point will be myopic. So as I'm drawing here, you can see here, I'm drawing a diagram of your simple myopic. So these three rays will be going to pass here, again the same diagram repeatedly coming, right? So the one focus point will be going to make here. for the retina. This is your f1 or f2, you can say, or the second focus point will be on your retina, f1. Okay, so the one focus point on the retina, the one focus point myopic. This is known as your simple myopic astigmatism. What is it is known as? It is known as your simple myopic astigmatism. If I'm talking about the simple myopic astigmatism treatment, if I'm talking about this treatment, as I already told you, in the myopia, what we are using the minus lens, or we can say the concave lens. Okay, this concave lens, but this time we are not using in the spherical form, we are using in the cylindrical form. Okay, what will you are using? We are using the cylindrical form. Now, what is the mean of a cylindrical form? Just I'm going to explain you. So we have the cylindrical, in the cylindrical form, we have the power only on the one axis. If I need the power is here, like minus 2, so the minus 2 will be on this axis. On the other axis, I have the power of 0. Okay, but if I'm comparing with the your spherical one, so spherical one, this is your cylindrical, right? This minus 2 diopter cylindrical, and I'm giving you the minus 2 diopter spherical. If I'm talking about the spherical, so minus 2 will be on the both axis. Okay, so I hope now you can understand what is the spherical mean by the spherical and what is the mean of your cylindrical. I think it was not visible, it is just behind me, so just check it out here, right? Just check it out here. Okay, just I'm taking out to the different side. Just give me a minute. Okay, now it's quite easy, right? So this was your cylindrical, which is having the power only on one axis. Although the secondly one, the spherical, we have the spherical type. This spherical type is having the power on the both of the axis, right? So this is the difference between the your spherical and the cylindrical. But please remember, if I'm talking about the your simple, if I'm talking about your simple astigmatism, what if I'm talking about your simple myopic astigmatism, so I will only use the concave cylindrical lens. I will use what? I will use only the concave cylindrical lens. Okay, so this concave cylindrical lens will be going to used in this. Now moving forward for the next is about to your, the next is to about to your, what the next one is your about to simple hypermetropic astigmatism. Again, what will be happening here? Here will be also the two focus point, f1 and f2, but one will be the normal, and other will be your hypermetropic. If I'm talking about this, what will be happening, the clinical feature of it, or I can show you in the image. Just wait for it. I'm going to erase this everything, so it will be quite easy to you. So you can see this one image will be on the retina, one focus point. The second focus point will be just behind the retina, right? So this will be just behind the retina, will be seen to you. It will be looking like that. Okay, so this will be the focus point 2. So there will be also the two focus point. Just remember it about it, that in the simple type of astigmatism, if I'm talking about the simple type of astigmatism, one focus point normal, the second focus point, which is the name is given, is like that, like simple myopic, so it will be the one myopia, one normal. If simple hypermetropic, one is normal, second is the hypermetropic, like that. Okay, so again, the treatment part of it, if I'm talking about the treatment of this part also, so using in the treatment of it, we are using in the treatment of it, we have to use the plus lens, which is also known as your convex lens. And this convex lens is used in a cylindrical form again. Okay, they are also the cylindrical form. As I already told you, I'm giving you example here only, like plus 2 diopter cylindrical. So this is your plus 2 diopter cylindrical. You can see the one axis is only having the power. We can get access on the your horizontal or the vertical, how you need, we can get it like that. Okay, I will tell you how we'll get this, right? Just remember about it. And if I'm talking about the spherical, this is your spherical, plus 2 diopter spherical. So you can see in the plus 2 diopter spherical, it is both axes having plus 2. In the cylindrical, just we are on the one axis. Why I am using the cylindrical in this condition? Please understand the thing. Because My one focus point is having the normal, so I have to use the zero power at the one axis, because one is the normal is there. I don't have to add on there. I don't have to give the additional burden to that focus point because it is normal. So I have to give the axis on the one, because one focus point is already in the myopia, or one focus point is in our hypermetropia. So I have to use in this condition, the cylindrical lens only. I have to use in this condition cylindrical lens only. I hope you understand about the simple myopia, astigmatism, simple hypermetropic astigmatism. Now moving forward for the compound astigmatism. Now understand this compound astigmatism. You will going to understand about it. Okay, let's move for the compound type of astigmatism. And in this compound type of the astigmatism, we have again the two type of this. The first will be your compound myopic astigmatism. I'm writing in a short form because I have to write the more the things, so it will be not in the slide, right? And we have the compound hypermetropic astigmatism. So you understand about this simple one? Just tell me, simple myopic astigmatism and simple hypermetropic astigmatism is understandable for you. If you understand, give thumbs up in the live chat box. I'm waiting for your answers, guys. I'm waiting for your reply. If you understand about it, just give thumbs up. Just give thumbs up. So I will understand this thing that you understand that particularly very well. Waiting for your everyone's. Waiting for your everyone thumbs up. Very good. Very good, guys. Okay. Now, as you understand the simple one, moving forward for the now compound one. What is happening in the compound one? What is happening in this compound myopic astigmatism? In the compound myopic astigmatism, it is having the again the two focus point will be there, f1 and f2. This both will be myopic. Okay, so now as you understand this thing, you can say, sir, both will be the myopic. It means a simple, it will be the myopia only. Okay, it will be the myopia only. No, guys, please understand the thing that as it is having the both are having in the myopic, please understand one should be the greater than the second one. So the f1 should be more than greater than the f2, focus point 2. Now I can draw a diagram so you will understand this thing. This is your cornea, this will be your eye, and this will be three rays which is passing from here. And now you can understand as it is talking about the myopia. So the focus point 1 will be the myopia. So this will be the focus point 1, which will be on the myopia. You can see here, this is the focus 1, or the focus 2 will be here. And this will be one more myopic focus will be here also. There is a 2 focus point. This will be the f1. So you can see here, the focus 1 is more than the focus 2. Okay. So the focus point 1 is more than the focus point 2. So now you can understand in this. There's the focus point is different, right? So there's a different focus points are there, right? So you can understand about it. So we have the different focus point. So the different focus point is having the different work, right? So the both are the different focus point will be there. Now in this condition, now the important of this condition that we have talked about the treatment part of it. If I'm talking about the treatment part of it, just understand, if I'm talking about the treatment part of it, what will be the treatment? Can anyone of you can tell me in the chat box? Can anyone of you can tell me in the chat box what will be the treatment? As the both are in the your both are in the your map. So in the treatment part, please understand, in the treatment part, the same will use the minus lens, or you can say the concave lens. And but concave lens, I have to use the spherical and the cylindrical both. Yes, I will use the both. I will use the cylindrical also. I will use the spherical also, because I have to manage the both of it. So I will use the both. So now you can understand, if the glass prescription is given like that, -2 diopter of spherical and the -1 diopter of cylindrical at the axis of 90 degrees. So as you saw, spherical, cylindrical, minus minus. So what will be your answer? Your answer should be compound myopic astigmatism. What will be the answer? Your answer should be your compound myopic astigmatism, compound myopic astigmatism, right? So this is about your compound myopic astigmatism. The same thing I have to talk about the now compound hypermetropic astigmatism. If I'm talking about the compound hypermetropic astigmatism, again there will be also the focus point. Two focus point will be the f1 and f2. Please remember the both will be hypermetropic. Okay, so your both focus point will be the hypermetropia. Dono focus point hypermetropia. Yes, but again the same thing is here. There should be the f1, maybe anyone of f1 or f2. The focus will be greater. One will be the surely greater. Okay, one will be the more will be there. Like I'm giving you the example of it. So you can see this focus point is here. So we have to draw the myopia. So you can see like that. I'm drawing is the myopia. Okay, so one is like that, and the second one will be more far. Okay, so the more far will be from this like that. It is making like that. Okay, so the focus point will be should near this. Okay, so this will be the f2, this will be your f1. So f1 should be the more greater than the your f2. So you can see here the focus point, the both focus point are the hypermetropic, both are behind the retina. As the both are behind the retina, this both are your compound hypermetropic astigmatism. And this condition, if I'm talking about the treatment, guys, please understand the thing, the same thing we have to use the treatment. We have to use the plus or the your convex lens. Your convex lens should be used as the spherical also as the cylindrical also. The both will be used. Okay, so we have to use the both type of the cylindrical lenses compound in the compound hypermetropic astigmatism. The plus lens should be used in your spherical also and in your cylindrical also. Just I'm giving you example. +5 diopter spherical. I think I have to write on this side because it is just behind me, so it will be not clearly visible to you. Okay, right, like here, right? Okay, so I think now it's visible, right? +5 diopter spherical, just +5 diopter spherical, and we have the +2 diopter cylindrical on the axis of 180 degree. So what will be the your diagnosis? It should be the diagnosis as the compound hypermetropic astigmatism. As you saw, the both lenses used. Spherical is also used, and your spherical, with the spherical you are using your the spherical is also used, and you are using your cylindrical also, and both are the plus. It means this is your compound hypermetropic astigmatism, compound hypermetropic astigmatism, right? So this is about the your compound hypermetropic astigmatism. And the last one, which is the mixed astigmatism, it's a very good and the rare type of astigmatism. There is also the focus point. Two focus point will be there, f1 and f2. As you already know, astigmatism, the word is astigmatism is there, it means it will be the two focus point, right? There will be should be the two focus points. So now the one and important thing is there, the one focus point, the f1, I'm giving you the example. The one focus point should be in your myopia, and the second other one is in your hypermetropia. Okay, the other one is your hypermetropia. This is the kind of a real type of the astigmatism. So you can see here, I can draw it here, so it will be easy to understandable for you. Just give me a minute. So this one will be the one focus point will be in your myopia. This should be your f1, and the second one will be on your f2 will be in your hypermetropia. So you can see here the one is focus point will be on the your on the your on the your on the other hand, on the one is on the, your myopia, the second will be on your hypermetropia, on the hypermetropia. So what will be the treatment part of this part? Can you understand this thing? What will be the treatment part? Yes, on the treatment part we have to use the convex plus concave lens. One should be spherical and one should be spherical and one should be cylindrical. So now you can see, as I can write here, and just remember it here, the cylindrical will be the always the cylindrical will be more. Okay, what do you mean? Like I'm giving you -2 diopter spherical and +4 diopter cylindrical at the 180 degree. So you can see the spherical is here, the cylindrical is here, the both is used in this condition. and you see the cylindrical is more, and although you can see the both signs are there, plus minus sign is also there, the plus sign is also there. Just a minute, I can do one thing so it will be clearly visible to you. Just a minute. Okay, now it's visible to you, right? So minus 2 is also there, you can see, and plus 4 diopter is cylindrical is also used at the 180 degree, right? So minus plus, when you are seeing the minus and the plus, when you are seeing the minus and plus both in one, both in the, if you are seeing the both in a one glass prescription, so you will understand the thing. You have to understand the thing. There is a which type of astigmatism. It is a mixed type of astigmatism. So with it, we finish with the astigmatism. I hope you understand with this, and surely I'm giving you the surety that this is a very important topic related to the astigmatism, and it can become into your exam. Right. So remember, with the all the type of astigmatism, I am revising you that totally this is the three type of astigmatism is divided. Simple astigmatism, it is having the simple myopic astigmatism, simple hypermetropic astigmatism. Then we have the compound astigmatism. In the compound astigmatism, we have the compound myopic astigmatism, compound hypermetropic astigmatism, and the last one, which is we having the mixed type of astigmatism. Right. So this is all about the astigmatism. This is all about your astigmatism. Moving forward for the next one, it is your anisometropia. If we are talking about the refraction, in the refraction we have to talk about the anisometropia. And what is the mean of your anisometropia? Just quite easy thing. The anisometropia condition is the asymmetric refraction between the two eyes. It means my one eye is having the different power and the second is having the different power. It is known as the anisometropia. That there should be the difference one or more than the one diopter in the spherical should be there. So it means, like I'm giving you, this is the right eye, this is the left eye. I'm giving you an example of it. The patient is having -3 diopter spherical in the right eye. The patient is having -5 diopter of spherical in the left eye. So this is the there is a difference, variation between the left and the right eye. Between these two eyes, the -3 and -5, there will be a difference of -2, right? So more than one. Please remember, more than one. It is known as your anisometropia. This is known as your anisometropia. Okay, let's move forward. For the next is your accommodation. If I'm talking about the accommodation, in this accommodation, what is happening? The accommodation is your, the eye is ability to the adjust to the focus to see on the object clearly at the distance, different distance. Okay, so I'm giving you the example. It is more working in your near object. Okay, focusing on your near object. So like I'm giving you an example. I'm seeing a far object and suddenly I saw the near object, like I saw my mobile phone. Right. So what will be happen the suddenly? What will be happen the suddenly? There will be the difference between the power, because the power difference will be there. So this lens will be going to adjusting this power of it. So it is need the more power to focus on the your near object. It will be need the more power to focus on the near object. So what it will do? It will increasing the power. For the increasing it the power, it have to do the three things in this thing. So for increasing the power, how it will be going to increasing? So the important thing is here you have the one here is your ciliary muscle or ciliary body. The first structure will be here. Ciliary body will be here. The second is your ciliary zonules. Ciliary zonules, or you can say the suspensory ligament. You can say this is the second, and the third is our lens. That is our lens. I'm talking about it. This is about the near object. So when I have to see the near object, so what I need the more power. As I already told you, if the curvature is increasing, the power is increasing. Okay, the curvature is increasing, the power is increasing. So as I need the more curvature, so please understand. So for the need the more curvature, I have to see what the happening will be. The your ciliary body will do the contraction. And just remember the one thing, your ciliary body and the ciliary zonules, or the suspensory ligament, are just opposite of it. If your ciliary body is doing the contraction, your ciliary zonules will do the relaxation. Okay, what it will be done by? It will be done by, from the ciliary zonule will do the relaxation. As the ciliary zonule will be going to relaxing, so your lens will be getting increasing the curvature. As it will be going to increasing the curvature, your lens or the eye power will be going to increase, and you can see the clearly the near object. You can see the clearly near object. But this is the near object, and now from the near object, suddenly I want to see the far object. As I saw the far object, so what will be happening in this far object? What will be happening in this far object? Again, we have the ciliary muscle, which is known as the ciliary body, right? Then we have the ciliary jonules, which is known as your suspensory ligament, ciliary jonules, and the last one is your lens. So the ciliary body, this is just the opposite of your near object. What will be happen? We need the lens will be decreasing the curvature. So for the decreasing the curvature of it, the ciliary jonule should be contraction. Yes, the ciliary jonule will do the contraction. As you can see, the ciliary jonules will be getting contracted, so the lens will be getting flattening of it, and it's need the contraction. And you know, the ciliary body and ciliary jonules are just opposite of it. So the jonules are doing the contraction, so the ciliary body will do the relaxation. Okay, so the ciliary body relax, ciliary jonules contraction, decreasing the curvature of it. If ciliary body contraction, ciliary jonules relaxation, there will be the increasing in the curvature will cause in the near object. So this is known as your accommodation. So just give me thumbs up in the chat box and like this video. Tell me if you understand this concept of the accommodation, because this is a very important topic related to accommodation. Let me know. I'm waiting for your answers, guys. Let me know. Did you understand this thing? Did you understand? Very good, guys. Very good. Okay, very good. Okay, so if you understand this thing, this is about the accommodation. Just related to the accommodation, one more thing which you have to come on it, which is known as your presbyopia. Now, what is the mean of your presbyopia, guys? It is not a refractive error. It is not a type of a refractive error. It is the error in there is a loss of accommodation. Loss of accommodation. It is not the error of accommodation, but it is the condition where through the age related, there is a physiological insufficiency, or you can say the physiological decreasing in the amplitude of accommodation. Okay, so as the physiologically it is going to decrease in the accommodation, so the accommodation will be not happening perfectly, and due to this it will be the patient usually near the age of 40 years of the onset of the presbyopia. The patient is facing the problem to see the near object. So the patient is not having the hypermetropia. Please understand the thing. Patient is not having the hypermetropia. The patient is having the near object problem. Patient is good in the far object, and the presbyopia, it is the physiological, not the pathological. It is a physiological decreasing in the amplitude of your accommodation. So what will we do in the treatment part of it? Can anyone, if you can tell me, as the near object is not visible, so we'll give the plus lens, or you can say it is the convex lens, right? Convex lens should be given. The convex lens should be given in a spherical form. Please remember, in the spherical form should be given, right? So we'll give the plus lens or the convex lens in the spherical form, in the presbyopia, right? Next, I'm moving forward for your related to your refraction. We have to talk about the retinoscope procedure. What is the mean of your retinoscopy? Yes, in the retinoscopy, this is the retinoscope instrument which you can see on your screen. It is looking like similar to your direct ophthalmoscope, but the difference is here. Yes, light will be going to fall from here, right? And the dial was here. This is the eyepiece, and this is your dial. So dial of your direct ophthalmoscope was on the side of the body. It was on the side of this body. But where is your dial of your retinoscope? On the neck of it. On the neck of it. You can see this is the neck of your retinoscopy. So what will be happen as I turn on this retinoscope? It will be going to falling a reflex, and this is known as this reflex, which is you seen here. It is known as your retinoscopic reflex. Okay, this is known as your retinoscopic reflex, and I have to see this retinoscopic. Before doing this retinoscopy, I have to dilate the eye, and for the using the dilation of the eye, we have to use the dilator cyclophagic drugs. What we have to use, guys? We have to use the dilator cyclophagic drugs. For using this dilator cyclophagic drugs, you know the eye will be going to dilate it, and after the making the dilation of your eye, we have to do this test. And how to do this test? We will move this instrument, and we have to see the movement of the reflex, right? Which reflex is there? We have to see the movement. So there is a two movements are going to possible here. The one which is the neutral. The first one is the neutral. It means if I'm going to moving my hand or the my retinoscope to the right side or the left side on the up and down, this reflex will be not moving anywhere. It means the patient is your emmetrotropic. It means the no refractive error will be there, or the patient is the normal. We can say like that. The secondly, I can get the width movement. What do you mean by the guys width movement? I can tell you the width movement. That width movement is what the patient, as I'm going to, I'm seeing this patient's eye, the reflex is on there. As I'm moving into the right side, the reflex is also moving with the right side. As I'm moving on the left side, the reflex is also moving. This is the my hand is the reflex, and this will be the your my retinoscope. So you can see it will be on the right side. As I'm going to the on the upside, it will moving on the upside. As I'm going to downside, it will going with my downside. So if the patient is having the width movement, it is having the hypermetropia or the myopia less than 1 diopter spherical. Okay, less than 1 diopter spherical. This is just remember about it. I will tell you now. I will show you how to do this. How to do this? Just wait for it. I will show you shortly. The second one, we have the against movement. What do you mean by the against movement? Now tell me this. Understand this thing. This is the reflex which is on the retina, and this is the my retinoscopic reflex. As I'm going to the right side, this reflex will be moving on the left side. As I'm coming back to the neutralization normal position, it will come on the center. As I'm moving my retinoscope on the left side, this reflex will be going to the right side. So this is moving against. Yes, as I'm going to left, it will go to right. If I'm going to right, it will go to the left. So it is the opposite of it. So this is known as the against movement, and the against movement is seen in your myopia more than 1 diopter. If the patient is having the myopia more than the 1 diopter, so this will be the, there will be the, what is the patient is having the against movement. So in the against movement, it means the patient is having the myopia more than 1 diopter, more than 1 diopter. So this is the about your against movement and your with movement. So I think I have to show you the against movement and with movement, right? So this is through this link I will show you. Just a minute, give me a minute. Give me a minute. So I will show you this retinoscopic procedure to all of you. I think it's the screen 3. Hello guys, welcome to. Just a minute, guys. I think. Yeah, it's visible. Very good. Okay. As it is visible to you, now I can show you. Now I can show you, right? It is on the visible on the screen. Okay. Now I'm going to show you how it will be going to work. How it will be going to work. So you can see here. Just a minute. Okay. Visible, right? It's clearly visible to you, everyone. Very good. So you can see here, this is the patient of is in front of you, and the patient is having the no power. So as it is, I started this retinoscope. I'm moving it with my hand. So this patient is having the neutral. What the patient is having? The patient is having the neutral, right? So first of all, I'm going to tell you about the hypermetropic patient. सबसे पहले हम किसको लेंगे? Hypermetropia का patient लेंगे. So this patient is having hypermetropia of +3. So with, as I told you, hypermetropia patient or the myopia till 1, the patient is having the what? The patient is having the width movement. So you can see here, as I'm moving my hand to the right side, you can see the reflex is also moving with me. I'm coming back to the centralizer position. As I'm going to the right side, this will be going with me to the right side of it. Again, if I'm moving it the straight onto the horizontal movement, and if I'm going to the upside, it will go with the upside. The reflex will be go with me the upside. If I'm moving to the downside, this will go with move with me the downside. So this is known as the width movement. What is known as width movement? It means I understand with this retinoscope that this in the retinoscopic procedure that patient is having what? The patient is having the width movement. It means the patient is having the hypermetropia or the myopia till -1. Now I have to show you the against movement. As I have to show the against movement, for the against movement, the patient should be the more than -1 diopter, right? So -1 diopter should be there. The patient should be there, right? So you can see here now, as I'm moving my hand onto the right side, the reflex will be moving on the opposite side. Can you see? It went to the left side. As I'm moving back again to the normalization, it will come back to the normal. And as I'm moving on the right, on the left side, this reflex will be moving on the right side. So this is the against movement. This is known as your against movement. What is known as against movement? As I'm showing you in the up and down side. So if my retinoscope is moving on the upside, the reflex will be go to the downside. If I'm back to the neutralization, it will be the neutral. And if I'm moving to the downside, this if I'm moving to the downside, this will be going to the upside, right? So this is known as the against movement. This is known as your against movement. And in the against movement, you already know what do you mean by this against movement. What do you mean by this your against movement? Yes, your against movement should be your against movement. Just a minute, guys. Okay, your against movement should be seen in which conditions? Your against movement is seen in the conditions of myopia more than 1 diopter spherical. I hope you understand this retinoscopic procedures also. After moving with the retinoscopic procedure, we have to see nowadays we are using the autorefractometer. I hope you saw this instrument in your ophthalmology clinic when you went to your ophthalmology checkups, right? So what you are seeing, the patient is sitting on the other hand, and doctor will be making this computerized autorefractometer, and this autorefractometer directly gives us a slip that is giving us the about your refractive error. So we don't have to do the retinoscopy, because retinoscopy is taking a too much time taking procedure. Okay, so the retinoscopy is your time taking procedure. What is it? It is your time taking procedure. So that's why will not do nowadays the retinoscopy. But please remember, the retinoscopy is your gold standard. Gold standard means it is the best one. Okay, if I'm talking about it, this is the सबसे best ones होगा. It will be the best one. Okay, it will be your best one. Okay, so now moving forward for the next, if I'm talking about the treatment of your refractive errors, as we saw the refractive errors, all the type of the refractive errors. So what is the treatment? Of course, the treatment should be the spectacles, which is the best one, right? We can say the best, right? Why the best will be? Because it is the easily available. The availability of the spectacles or the glasses will be the easy available, and the cheapest also, right? It will be not costing too much, right? The second one, we can use the contact lens also. The second one, we can use the contact lens also. The contact lens, we can use the two types of the soft lens are here. Hard lens will be available there, right? And the regular lens will be available there. So through the contact lens also, you can go with the doing the treatment of their refractive errors. The third one, which will be your refractive surgeries. Third one will be your refractive surgeries. So you can understand with this, the refractive surgeries we have to do in the conditions where we have to remove the specs or remove the refractive errors. So the first one, which will be known as the LASIK. In the LASIK, what we are doing, laser assisted in situ keratomyelitis. What do you mean keratomyelitis? Keratomyelitis, what we'll be doing? We are doing the changing in the curvature of your cornea, right? It's the keratomyelitis. The second will be known as your phakic intraocular lens. Through this phakic intraocular lens, we'll putting a extra intraocular lens in front of your normal lens, right? So we are putting an extraocular lens in front of your normal lens, and it will be also a refractive surgery. And the third one will be your photo refractive keratometry. In this condition also, we are doing with the photorefractive, we are doing the changes in the cornea, right? Changing in the cornea. So this is about your three type of the refractive surgery. So this is about the treatment of refractive errors. Should we move forward for the next? We have to talk about the conjunctiva. So what do you mean by your conjunctiva, guys? What do you are understanding by with the word conjunctiva, right? What is the meaning of conjunctiva? The conjunctiva is a thin layer, right, which is a clear membrane, or to the transparent membrane. You can say the transparent membrane that covers the inner surface of eyelid. So your eyelid is covered from the inner side, and the white part of your eyeball, which is your sclera. So your your conjunctiva is covering your this part of your eyelid. From the inner side of the eyelid, I'm talking about the layers of the eyelid, the innermost layer of your eyelid is your what? The innermost layer of your eyelid is your conjunctiva. It is your conjunctiva, right? And there is a and your sclera, your scleral part is also covered with your conjunctiva. Please remember, the cornea is not covered with your conjunctiva. Cornea is not covered with your conjunctiva. So please remember, this scleral part is also covered by the conjunctiva. So the type of the conjunctiva, yes, there is a two type of the conjunctiva. The one which is known as your palpebral conjunctiva, which is covering your inner eyelid, okay, inner side of your eyelid. The second one is known as your bulbar conjunctiva, which will be going to cover your scleral part of your eyeball, and where the palpebral and the bulbar, where the palpebral and the bulbar conjunctiva are meeting together, the junction of this is known as your fornix. This is known as your fornix, right? So palpebral conjunctiva and the bulbar conjunctiva are meeting at this point. This is known as your fornix. It is known as your fornix, right? So let's move forward for the diseases part of the conjunctiva. We're starting with your allergic conjunctivitis. We're starting with the first disease, which is known as your allergic conjunctivitis, or also known as your spring catarrh, which is known as your spring catarrh. So spring catarrh भी बोला जाता है. The full name of it is your vernal keratoconjunctivitis. What is known as your vernal keratoconjunctivitis. Okay. VKC. The vernal keratoconjunctivitis, the VKC is your type 1 hypersensitivity. Please understand, it is having the hypersensitivity type 1 reaction and through the exogenous allergen. So there will be the allergic, as I told you, this is the type of your allergic conjunctivitis. So what will be there? There will be the allergens will be shown on the allergens will be seen on your exogenous allergens will be, and through this exogenous allergens we can see the the hypersensitivity reaction type 1, and this is the type IgE cell mediated, or you can say the eosinophils, right? Eosinophils and the IgE is the mediated. The more commonly it is seen in the boys. Please understand this part. This more commonly seen in the boys, highlighted because rather than the girls, right? And what is the age? Age is from the 4 to 20 year of the age. So if the patient is given to you, the 1 7-year-old or 10-year-old boy is coming to you with your uh, hypersensitivity type reaction 1, or the having this itching, what is the important? The itching will be there more, na? Itching, ropey discharge, and the patient is having the redness of the conjunctiva. So this will be the clinical features of the scene, the vernal keratoconjunctivitis. What is the importance there? The important features will be seen there. It is your cobblestone appearance. The first is your cobblestone arrangement, or you can say the cobblestone appearance of the papillae, and the second one will be your Horner tanta spots. Horner tanta spot. This both of the images I included here. So this is your cobblestone appearance. This is your cobblestone appearance, and this one will be your Horner tanta spot. What is the mean of your cobblestone appearance and the Horner tanta spot? Please understand the thing. So due to this, as it is it is the allergy type of the conjunctivitis. So the palpebral conjunctiva on the tarsal, it means on the upper eyelid, it will be getting flat topped elevation. What it is getting? It is getting a flat from the surface. It is having the flat topped elevations. The elevations are here. This flat topped elevations are there, and this flat topped elevation and this flat topped elevations are known as your cobblestone appearance. What it is known as? It is known as your cobblestone appearance. Although we have the second thing, we have on the other side, we have the round shaped follicles on the your round shape of the follicles on the your on the upper tarsal or the upper limbus. You can see on the upper limbus, and this is known as your Horner tanta spot, and this is also seen in the case of your vernal keratoconjunctivitis in the VKC, in the case of VKC. All right, the next, if I'm talking about it, the Horner tanta spot and the ropey discharge, the patient will be having the ropey discharge in the pathogenic. So it will be the patient. If I'm talking about the treatment part, of it, so what will be the treatment? As it is the allergic condition, we have to give the antihistamine. Okay, so we'll give the antihistaminic, topical antihistaminic, guys. Topical antihistaminic should be given. Also, if it is not with the histaminic, so we'll give the topical steroid. Topical steroid should be given. And if it is not by the steroid also, so we can give the topical immunomodulator. Okay, so we can give the topical immunomodulators can be given to this patient. But this is the case when the patient is coming to one time. But please remember, this is a recurrent type of this, right? It is having the recurrency also. So if the patient is having the recurrency, so we'll give the prophylaxis treatment also. In the prophylaxis treatment, we'll give the mast cell stabilizer. Okay, so what we'll give? It will give in this condition, mast cell stabilizer should be given. So this is about the treatment. So this is the new case. Please understand, if the new case is there, and this is seen in the prophylaxis. Okay, so if you give the prophylaxis, then give the mast cell stabilizer. So this is about your allergic conjunctivitis. After the allergic conjunctivitis, we have one more, phthalmic conjunctivitis. The name is known as your fictanicular keratoconjunctivitis. So what is the mean of fictanicular keratoconjunctivitis? There is a fictan is seen. What is the mean of fictan? Fictan is a kind of a nodule. You can see this nodule. This nodule is known as your fictan. This fictan is a pinkish white nodule. You can see on the image as I shown you, right? So this is the fictan is your pinkish whitish nodule, 1 to 3 mm in the size, surrounded with the hyperema. What is the meaning of hyperema? More vascularity on the bulbar conjunctiva. On the bulbar conjunctiva, it will be seen on the bulbar conjunctiva, usually near the limbus. Where it will be seen? Yes, it will be seen is usually near the limbus. So you can see this will be the limbus, so it will be the near the limbus. It will be good to see. And what type of this hypersensitivity? Please remember, it is a delayed type of hypersensitivity. It means it is your type 4 cell mediated hypersensitivity. It is your type 4 cell mediated hypersensitivity is seen in this condition. And as this is the type 4 cell mediated type 4 hypersensitivity will be there. Please understand, it is seen in the which disease. What is the cause of it? The most common cause is in India. If we are talking about India, in India it is the tuberculosis. If we're talking about the worldwide, it is your streptococcal. So the worldwide, what we have? Worldwide we have the streptococcal. These are the most common cause, and please understand this more common in the girls. If I'm talking about the VKC, the vernal keratoconjunctivitis was more common in seen in the your boys, but your fictanicular keratoconjunctivitis is more commonly seen in the girls, right? And this is the more commonly in the girls between the 3 to 15 year of the ages, right? And this is also having an important, which is known as the fascicular ulcer or the miliary ulcer. What is happening if this fictan will be going to grow, and after the growing it, if it is going to involve your corneal part also, if it is like that, and it will be going to involve your corneal part also. अगर cornea में involvement हो गया fictan का, so this is known as the fascicular ulcer. Now this is known as your fascicular ulcer or the miliary ulcer, right? Miliary ulcer. Talking about the treatment, so first of all, the drug of choice is your topical steroid should be given, as the worldwide the streptococcus is the most common cause, so only the steroid is given. But is in India, we have in India is the most common cause is your tuberculosis or the tubercular. The TB is the most common cause, so we'll give the steroid also, and we have to give the causative treatment. Like in India, what we'll give? We'll give the anti-tubercular drug. Okay, so we have to give the ATT. Okay, anti-tubercular treatment should be given. So in the India, we give the ATT. Okay, we have to give the ATT also. Okay, so this is about the your fictanicular conjunctivitis. After the fictanicular conjunctivitis, now it was both type of the allergic type of the conjunctivitis. Now we are moving for the degenerative. The degenerative conditions of the your conjunctiva, and starting with the your pterygium. Starting with the first one, which is your pterygium. In the what is the mean of pterygium? Yes, your pterygium is your elastotic degeneration with hyperplasia of the subconjunctival tissues in the front of vascularized granulation tissues, right? So it will be going to grow as you can say the elastotic degeneration of the conjunctiva. So you can see the normally we have the conjunctiva till the limbus, but now what is happening? This from above the limbus, it is going through the your, it is going above the your cornea, it is growing on the cornea, right? So that's what is the main important thing. The important thing, if we're talking about the cause, so the cause is the more exposure to the your ultraviolet rays or the sunlight, right? It impacts the etiology. So that's why it is more commonly seen in India in the farmers. Okay, but as the farmers are more working in the fields with the sunlight, so they are the more exposure to. If we're talking about the pterygium, so the pterygium is having the three parts, having the head, neck, and the body. So this is the head of pterygium, this is the neck of the pterygium, and this should be the body of the pterygium will be there, right? So it is having the three part of it. If we're talking about it, at the head, near the head, it's near the head. If there is a deposition of, there is a deposition of iron should be there, and it will be the iron will be going to deposit it at the corneal epithelium at the near the head, and this is this is known as your Stocker's line. If the iron is deposited at the head of pterygium, it is known as your Stocker's line. So it will be seen like that. Okay, Stocker's line will be going to seen like that. So this is known as your Stocker's line. It will be should known as your Stocker's line. So what should be the treatment? Yes, please remember, if you are doing the just surgical removal, just normal excision. So the recurrence after the surgery removal should be the 30 to 50%. It can be recurrence there. So for avoiding this recurrence, bar now, right? So what we are doing the conjunctival autograft should be done from the avoiding the recurrence. So what we'll do, we'll cut it like that. We'll cut from here or the limbus and we'll remove this part and we'll take a small part from the limbus of the same eye. We'll take the same eye. What we'll take the from the same eye, we'll take a part of from the limbus part, we'll take a graft and we'll graft here. We'll put the graft here. So it is known as your conjunctival graft. And please remember with this, if we are doing the excision plus conjunctival autograft, there will be the recurrence will be the very low. The recurrence will be the very low will be there, right? Right. The next, it is the conjunctiva is already covered. Now we are moving forward for the cornea. Now we are moving forward for the cornea. In the cornea, we have to talk, as we already talked about it, about the break. Just we'll finish this and we'll give you a break. Okay, just wait for it. Just wait for the more 20 minutes. Okay, just 20 minutes. Okay, we'll take a break. Okay, now talking about the cornea. If I'm talking about the cornea, in the cornea, we have to talk about the keratitis. Okay, then importantly, we have to talk about the keratitis in the cornea, and which is known as your corneal ulcer, which is known as your corneal ulcer. The 5 type of the important corneal ulcers we have to talk about it. The first one is it's depending on the, it is depending on the what? It is depending on the your cause of it. What is the causative organism, or the what is the causative organism is there, that is the depending on the name of the ulcer will be on the, or the name of the keratitis will be on that. Like the bacteria is there, so that this is known as the bacterial corneal ulcer, or you can say the bacterial keratitis, or you can say the fungus is there, the fungal corneal ulcer, fungal keratitis, herpes simplex virus, so it is known as the viral keratitis or the HSV keratitis. The acanthamoeba is there, so it is known as acanthamoebal keratitis, and the last one, which is your interstitial keratitis. So this is the 5 type of the keratitis we have to talk about it. So starting with the first one, which is your bacterial corneal ulcer. Now understand about this bacterial corneal ulcer. This is a single ulcer having the sharp margin. So what is the important? Single ulcer having sharp margin, more symptoms. What the main be the symptoms? There will be the pain, photophobia. Okay, pain, photophobia will be there, and the patient will be having the more pain, photophobia, redness. Okay, so these symptoms will be more pronounced in this condition, right? If we're talking about the diagnosis, how we'll make this diagnosis? So we can do the corneal scraping, and we can do the gram staining, or we can do the culture on blood agar. Okay, so we can do the corneal scraping, we can do the gram staining of it, and with the gram staining we can do the culture also on the blood agar. We can do the culture on the blood agar. If I'm talking about the treatment, what should be the treatment of your bacterial ulcer, guys? What should be the treatment of your bacterial ulcer? Of course, we have to give the antibiotics. Okay, we have to give the antibiotics. With the antibiotics, we have to give the pilocarpine. Mitotics should be given for the decreasing the pain, and we can add on here the lubricants also. Okay, lubricant should be added there. So antibiotics should be given, pilocarpine as the mitotic should be given, and the lubricant should be given. And this is the case of your corneal ulcer. This is the case of your corneal ulcer. If I'm talking about the now fungal ulcer, you can see the fungal ulcer is having the multiple ulcer. Okay, what is having multiple ulcers are there? What you can see, this is the one ulcer will be here, one ulcer will be here, right? So the multiple ulcer, and margins are phasy and feathery. You can say the hazy and feathery, so it will be much better, right? Hazy, so it will be not, you cannot identify the particularly it. Okay, multiple, the phasy and feathery. If I'm talking about it, this is the hazy and feathery, and please remember here it should be the vegetative matter injury, history should be provided by the patient. History should be provided by the patient. So the vegetative matter, like your grass, like your we can say the limbs of the leaves of the trees, grass should be there. So whatever the things will be there, the stunt of the your tree, like that, the vegetative matter history should be given in this condition. And you can see here there should be the production of your exudates will be seen there. This is known as your hypopyon. This is known as your hypopyon. This is known as your hypopyon. If I'm talking about the diagnosis of it, for the diagnosis of it, your fungal ulcer, we can do the corneal scraping and do the KOH mount. We can do the KOH mount, right? KOH staining, and we can do this grow on the your agar. We can do the culture also. Culture should be done. If we're talking about the treatment part, so in this we will give the antifungal. Okay, antifungal should be given. Also, we can give the pilocarpine as the mitotic drug, and we can give this patient antifungal. We can give the pilocarpine and give the we can give the lubricants also. If we're talking about the symptoms, less symptoms. Okay, patient is not feeling so much pain or not feeling so much redness will be not there. So the symptoms will be less pronounced. Symptoms will be less pronounced. Let's move forward for the third one, which is your herpes simplex corneal ulcer. As you see, this is the viral type of corneal ulcer. So first of all, you can see here, you can see this is your dendritic ulcer. What is this? This is your dendritic ulcers. Okay, this is your dendritic ulcers, right? Which will be clearly seen on your HSV. If we're talking about it, so it is a painless. Why the painless? Because the virus will be going to involving on your layers of the epithelium on this the particularly, so it will be going to do the involvement of your nerves also. So this will be the painless type of your keratitis, or right, painless type of the keratitis. Painless also, if we're talking about it, so there will be the if you want to do diagnosis of it, so that in the diagnosis we'll do the will inject the fluorescent green dye, and we'll use the cobalt blue filter on your slit lamp by microscope. So you will be going to see the dendritic ulcer. What will be the scene? Dendritic ulcer. The painless will be there. If we're talking about it, this is the 5 type. This is the more the 5 types. As the layers of the cornea will be getting involved, like epithelium will be going to involve, this is known as the epithelial keratitis. As your Descemet membrane will be going to involve, it is known as the Descemet keratitis. As there will be the stromal layers, so stromal keratitis. So it is having the involvement of the all of the 5 of the layers, right? So layer by layer. So just remember about it. If I'm talking about it, so in the treatment part, please remember in the epithelial keratitis, we have to give the antiviral, which is your acyclovir 3% eye ointment. Okay, acyclovir 3% eye ointment should be given. If I'm talking about the all others type, there should be the steroid. The answer should be your steroid should be given. If the commonly they didn't mention any type of it, and they ask you just directly the patient is having the HSV and they're asking you about the drug of choice, just go with the steroid. Okay, just go with your steroid. Just go with your treatment part of your steroid. Okay, so this is about your viral keratitis. The next we have the acanthamoebal keratitis. In the acanthamoebal keratitis, there is the patient is having the more pain. More pain will be there. The patient is having more redness. The patient is having the more pain, more redness will be there, and the patient is having the history of contact lens used. Okay, so the patient is having the history of contact lens use. So patient ने क्या use किया है? Contact lens use किया है. Specifically, if you are want to ask it, there will be the seen a type of ring ulcer. You can see it is a kind of a ring is seen into the eye. Above the cornea, you can see the ring. So this is specifically on the ring. If I'm talking about your treatment part, so we have to give the PHMB. So this should be the drug. So you have to give in the acanthamoebal keratitis, right? Quite easy, right? Moving forward for the now in the degenerative causes of your uh, cornea, it is your keratoconus. So what is the mean of your keratoconus, guys? Please understand this thing. The keratoconus is your non-inflammatory actical conditions of the corneal graving. This cornea is getting the conical shape, which is the resulting into the irregular. So the patient is facing irregular myopic astigmatism, and it is usually bilaterally seen in the 85% of the cases, and it is more commonly seen in the girls after the puberty. It is more commonly seen in the after the girls of the puberty. So this is the keratoconus. There will be the what? There will be the non-inflammatory axial growth of your cornea, and it is making a conical shape. It is making a cone of it. So what will be the happening in this condition? There will be the impaired in the vision due to the progression of this myopia. So the patient is facing the problem into the vision, and with this the patient is having the as the patient is having the irregular astigmatism, the patient is having the history of changing in the glasses. Okay, changing in the glasses frequently. Patient is facing in the changing in the glasses frequently. The second thing, there is a specific sign which is known as your Munson sign. What is the mean of your Munson sign? You can see here when we say to the patient to look downwards. When the patient is looking downwards, so this cornea is making a depression. The cornea is going to making a depression on the lower eyelid. Can you see this? This is known as your Munson sign. So this is known as your Munson sign. This is known as your Munson sign. The second one is known as your Vogart's triad. What is the meaning of your Vogart's triad? Yes, the Vogart's triad is given you here. Please remember, as the word is the V, Vogart's triad start with the V. This is known as the vertical stria on the descending membrane. So you can see this is the stretching membrane. You can see the vertical stria on the scene on your descending membrane. This is the stretching marks on the scene on the descending membrane. It is known as your Vogart's triad. This is known as your Vogart's triad. The next, if I'm talking about the next, it's your Fleischer's ring. And what is the mean of your Fleischer's ring? Please understand the thing. Here at the base of your cone, you can see the iron is getting deposited. As this iron is going to deposit it, this will be giving us the, when we are putting light into it, it is giving the reflection of it. So this is known as your Fleischer's ring. This is known as your Fleschner's ring, right? So this is known as your Fleischer's ring, right? So this is all about the keratoconus. If we're talking about the treatment part, we can give the RGP lens in the temporary, and if we're talking about the permanent treatment, we have to do the surgery. What the surgery? We have to do the corneal curvature, we have to decrease. So for this surgery, we can do the keratomalacia, right? We have to do the keratomalacia, or we can do the collagen cross linkage surgery. Okay, C3R CXR surgery. Okay, collagen cross linkage with the riboflavin surgery should be done in the cases of your keratoconus. Right? So let's we start the lens. Before the starting the lens, just take a break. Right? Let me know for how much minutes you need the break, guys. Let me know for how much minutes you need the break, guys. Yeah, I'm giving you the break, guys. Let me know in the chat box. Need the break or should continue? Need the break or should continue? Break. Okay. Okay. So let's take the 10 minutes break and we'll continue the class again. Okay. 5 minutes. Okay. Let's 5 minutes break is there. Okay. 5 minutes break is there and then we'll continue the class. Okay. We'll continue the class again. Okay. Let's take the 5 minutes break. Hello, hello, hello. Am I audible, guys? Am I clearly audible? Let's start the session. Am I clearly audible and visible, guys? Let me know in the chat box. Am I clearly audible and visible? We'll start the session. And one informative news I'm going to give you that please check your registered mail ID of your FMGE exam, which you filled in your exam form. So the NB is going to send you the particular mail for the test center. Okay. So they announce the test center. You filled the choices of the test centers, right? So they given you the particular your test centers is announced, right? So you can check it on your particular mails, right? Sure. Let's start the session. Just let me know or give the thumbs up in the chat box, so I will understand that the audio video is perfect. Anyone of can give me the thumbs up in the chat box, or just let me know once it's going perfect, right? Should I continue? Okay, perfect. Okay, let's start the session, and we are moving further for the next topic, which is your lens, right? So talking about the lens, in the lens we have to talk about the lens. We have to talk about the disease in the lens. We have to talk about the cataract, about the generally about the refractive index, about the power, refraction power. We already talked about it. I already mentioned you about this. So we have to talk about it now about the cataract disease. So talking about the disease name is cataract. What is happening in the cataract, guys? There is the clouding of the normal and the clear lens of the eye. There is a clouding of your normally clear lens of the eye. There is a clouding of your normally clear lens of the eye. If we're talking about it, the types of the cataract, there's a different type of the cataract. So this is the clouding of your cataract, the clouding of the lens. Already I told you the lens is the normally your transparent structure, right? So what is happening? There is a clouding will be happening in this, right? There is a clouding of the lens will be seen there. If I'm talking about the types of cataract, if I'm talking about the types of the cataracts, in the types of cataract we have the mainly five type of the cataracts which we have to learn about it. The first one is your senile cataract. First one is the senile cataract. It means the age related cataract, which is the most common cataract, which is the most common cataract, right? Senile cataract means the old age. In the old age, this is the age related cataract that will be seen in your old age patients, right? The next we have the second one, which is known as your metabolic cataract. It is seen in your some metabolic conditions. We'll talk about it, which metabolic condition. The third one is your seen in your toxic cataract due to the some toxins which we are ingesting that is causing the your that will be going to causing your cataract. And the fourth one is your traumatic cataract due to some trauma, and the last one, which will fifth, your miscellaneous cataract. So before starting the cataract, as I told you about the anatomy of your lens, we talked about the anatomy of the lens. In the anatomy of the lens, as you know, this is the anterior pole of the lens, this is having the posterior pole of the lens. So as I already told you, in the anterior part we having the epithelium. So you can see this, the anterior part is having the epithelium. What about the posteriorly? Posteriorly we don't have any epithelium. Posteriorly we don't have any epithelium, will be not there, right? So the posterior no epithelium will be there. So anteriorly we have the epithelium. The posteriorly no epithelium will be there, right? Also the outermost is the capsule is covering. The outermost is your capsule is covered there, and after this capsule, if I'm going inside, this is having the cortex, which is a periphery, which is the periphery of it. Is the peripherally from this we have the cortex and the nucleus, which is in the which is situated into the center, right? So this is about the lens anatomy. If I'm moving forward for the type first, which is a senile cataract, in the senile cataract, we have the nuclear cataract. In the nuclear cataract, as I told you, the nucleus is in the center of your lens. So you can see just only this clouding will be going to start it from where? The clouding will be going to start it from the nucleus part only. The cortical part, can you see the cortical part? Yes, the cortical part is clear. You can see the cortical part is clear, right? Just lens part, the lens nucleus part, the middle part or the central part of the nucleus is getting clouded. It is getting clouded, right? Also, if I'm talking about it, it is getting clouded. If I'm talking about it, what is the main features with it? There will the patient is having the index myopia. The first of all, you have to see about the index myopia. In the nuclear cataract, the patient is having the index myopia. what is happening in the index myopia? What is happening in this guy's index myopia? As I told you, there is a refractive index is there. So this index will be going to change. And normally we have the 1.33, right, for the lens. So it will be going to the 39 will be there changing 39, right? 1.39 will be going to changes into the now as it will be getting the dense, so it will be going to change into it as it is going to dance, so it will be going to change into it. So because of the changing into it, because to changing into it, uh, because of the changing into it, there the index myopia. In this index myopia, what will be the scene? There will the patient will be having like presbyopic glasses, है ना? So what will be the clinical feature? In the clinical question, they mentioned you the patient now can read the newspaper without the glasses. Okay, earlier it was having the presbyopic glasses, but now read without the glasses. Okay, newspaper without glasses. If they're mentioning you like that and they're asking you about the which what is the condition is that, so this is your index myopia. With the index myopia, the patient is having the visual difficulty in what? Visual difficulty कब होगी? The visual difficulty will be in the daytime or in the bright light. What is the main cause of it? Just remember about it. This is your cornea. This will be the behind we have the lens. Okay, and this will be the whole eye. Just remember about it. As the lens, the eyes will be going to, this rays will be going to passes from here. As in the bright light, what will be happen? Your pupil will be getting shorter. So just line the light can be passed into the central part of your lens to the retina, but the central part, which is your nucleus, is already getting what? Already your nucleus part is having the what? Having the clouding of the lens. So this is the patient is facing the difficulty in the daylight or in the bright light, okay, when the pupil is getting concentrated. So this is about your first type of the cataract, which is your nucleus cataract. The second type of the cataract, if I'm talking about in the senile cataract, we have the type 2, which is known as your cortical cataract, In the cortical cataract, as I told you, the cortex will be going to involve. So you can see the periphery is getting involved into it. The cortex part will be going to involve into it, and this cortical part will be arising. The cortical part will be getting making the arises on the cortex. Okay, so the central is clear. So what will be happening in this patient? The patient will be having visual difficulty in the patient is having the visual difficulty in dark light or in the night time. And they will give you what? The patient cannot drive the car at night. So this will be clinically they will give you. How this will be happening? The same thing as I told you in the nucleus one. So what will be happening now in the bright light? In the dark light, what will be happen? Your pupil will be getting dilated. As your pupil will making the dilation, the pupil will making the dilation on it. So due to the pupillary dilation, now this light will be passing through this cortical part, and this cortical part is having the cloudness of it. So as this is having the clouding of it, so due to this, the patient is having the difficulty in the night time or in the dark vision or in the dark time. Okay, so in the dark, the patient is having the visual difficulty in the dark light, or you can say in the night time, or the most commonly they mention in the MCQ that patient cannot drive in the night time. This is the cortical cataract. The next type of the senile cataract, the third one, which is the posterior subcapsular cataract. What do you mean by the posterior subcapsular cataract? As I told you, it is having a capsule. Just behind the capsule, the opacification is going to start. So behind the capsule, but it is the centrally. So it is looking like similarly, it is looking like to you the nucleus cataract. But when you are seeing on the slit lamp by microscope, you can clearly see the nucleus is separated. Nucleus is not getting involved with this. So nucleus is not involved into it. So the nucleus is separated. But the opacification is just behind the nucleus on the capsule, right on the capsule. So this is your capsular cataract. If we're talking about this, so this is a patient is having the difficulty in the vision. Again, tell me, where will be the difficulty in vision? Bright light or dark light? As it is in the central lights, it will be in the bright light. Or the daytime. Okay, in the daytime, patient is having the difficulty in the daytime, right? So this is known as your posterior subcapsular cataract. Moving forward for the next type, which is your fourth type. And what is this? Your mature senile cataract. Please understand, when your cortical, when your nucleus, when your posterior subcapsular cataract is not getting the treated, this cataract will be going to develop it into your mature cataract. And when it is going to convert it into the mature cataract, this mature cataract will be the totally white color, milkish lens will be going to see. What will be seen? Totally white, milky lens will be going to seen to you, and this is known as milk of bag. It is also known as a milk of bag, right? And this is your mature cataract. Of course, the visual difficulty whole time, or the in a day and night, both time, okay, because the visual difficulty will be the totally lens is getting clouded, also it is causing the complication. What is the complication of it? It is having the complication of phacomorphic glaucoma, or can cause the corneal edema. Okay, so it can cause the complication as the phacomorphic glaucoma, or can cause your corneal edema. So this is the year about the mature senile cataract. Now, if the patient is not getting treated in this mature senile cataract also, so now the patient will be going to land up into your hypermature Morganian cataract. So now the patient will be going to land up into your hypermature Morganian cataract, and this hypermature Morganian cataract is a kind of the the fully mature cataract. So what will be happen? Your cortex will be getting liquefied. This is your liquefied cortex, and this liquefied cortex is having this shrunken nucleus. So nucleus is shrunken down due to the gravity. It is below side, right? Shrunken down the nucleus, and it is having the liquefied the cortex. The cortex is totally liquefied, and this is known as the hypermature, or also mentioned as the Morganian cataract. And visual disturbance also, it will be also the fully visual disturbance. The complication of it, it is having the phacolytic glaucoma, or can cause this also corneal edema. It can cause the corneal edema, right? It can cause the corneal edema or the phacolytic glaucoma or the corneal edema. So this is about your hypermature Morganian cataract. Let's move forward for the next type, which is your metabolic cataracts. If I'm talking about the metabolic cataracts, in the first metabolic cataract, I have to talk about the diabetic cataract. In the diabetes of the cataract, you will going to see the cataract, which is also known as your snowflake opacities, or can say the snowflake cataract also. You can see it is looking like that in this image. The snowflakes are dropping down, right, into the lens. So the snowflake cataract, it is known as. And what is the cause of it? Due to the accumulation of your sorbitol. Now, what is the mean of your sorbitol? How it is the sorbitol in reach in this lens? Please understand this thing. Due to this, your aldose reductase. The aldose reductase is your enzyme. Enzyme is there in the lens, and this enzyme is what? This enzyme is doing the conversion of your glucose into sorbitol. The glucose will be going to convert it into the sorbitol. So normally we have the normal values of the glucose. So normally it will be going to convert into the the sorbitol will be going to convert it, and normally it will be going to use. But what is happening in the diabetes mellitus patient is having the more glucose in the bloodstream. So moreover, the glucose will be go into the lens, and the more and more conversion of this glucose into the more and more glucose will be going to convert it into the sorbitol. As it will be more and more going to convert into the sorbitol, this sorbitol will be now getting deposited into your lens, and this will be going to cause as your snowflake cataract. It will be going to cause as your snowflake cataract. The next type of the metabolic cataract, which is the type 2, which is known as your galactosemic cataract, which is also known as the oil drop cataract, right? It is also known as your oil drop cataract. It is looking like that oil, the drop of oil is put it on the drop of oil is put it on your lens, and this is the kind of your inborn error. What is the inborn error? It is your galactose metabolism. Inborn error in your galactose metabolism. What is the mean of galactose metabolism? Yes, guys, it is due to the deficiency of your glucose 1-phosphatase uridyl transferase. This is your GPUT. This is your enzyme is known as your GPUT. So this enzyme will be getting deficiency there. Due to this, the patient is having the galactosemia. And please remember, this is a kind of your reversible able cataract. What do you mean by the reversible cataract? If you are treating the galactosemia, this cataract will be getting resolved. This cataract will be getting resolved. The next one we have the third one in the metabolic cataracts. We have the sunflower cataract. In the sunflower cataracts, you can see it is looking like a sunflower. It is having a big base of it and having the small petals around it, and it is associated with the inborn error of your copper metabolism, which is also known as your Wilson disease. The important thing, this is having no visual disturbance. Okay, so the patient is not having any kind of visual disturbance due to this sunflower cataract, right? So this is known as your metabolic. This is a type of your metabolic cataract. Now moving forward, for the next is your toxic cataract. If I'm talking about the toxic cataract, can be due to the toxic substance. Like, first of all, the most common is your steroid. Okay, if the patient is having more consuming of the steroids again and again, so the patient is having the toxic cataract can be there. And maybe in the your ATTs, anti-tuberculous drugs, and your chloroquines, and many other drugs are having this causing the toxic cataract. So this is due to this ingesting of the substance like a drugs which is using for the treatment of the any other diseases can cause your cataract, which is known as a complicated cataract. You can say the complication of this particular drug which we use there. So this is the kind of a complicated cataract. Then the fourth one, we have the traumatic cataract. In the traumatic cataract, we have to see the specific type in the blunt injury. In the blunt injury, we have to see the flower rosette shaped cataract. What we see this flower which is having the rose type, okay, having the rose petals here. So this is known as your flower rosette cataract, and it is seen in your blunt injury. It is seen in your blunt type of injury of eye. And the last one, which is the miscellaneous type of the cataract. In the miscellaneous type of the cataract, we have this important type of the cataract which is seen in your disease, which is known as your myotonic dystrophica, and this is known as a very good named cataract, which is known as your Christmas tree cataract. What is the name of it? It is known as your Christmas tree cataract, and you can see it is looking like the Christmas tree. So this is your myotonic dystrophica. This is seen in your case of your myotonic dystrophica, right? So this is about your cataract. Now the cataract is, you already know, the cataract will need the treatment. No medical treatment will be for the cataract. The cataract should need the surgery. So the cataract surgery should be done. The cataract surgery should be the two types. The first one is your intracapsular cataract extraction, ICCCE, and the second one is your extracapsular cataract extraction, which is your ECCE. Right. So in what is we are doing in the intracapsular, we have to remove the whole lens with the capsule bag is also removed. So we'll remove all the lens with the capsule bag. So this will be your ICCE. Right. The next we have the ECCE. In this we have the two types of the surgery. First one is your small incision cataract surgery. The second one is your phacoemulsification surgery. What we are doing in this case, we are opening the capsule bag, which is known as your capsulotomy, and after the capsulotomy, we'll remove the lens, or we can remove the lens fibers. Okay, fibers of the lens will be getting removed, and please remember the capsule bag will remain behind. After the remain behind this capsular bag, we have to put the lens into it. So I'm going to show you the first about the SICS, small incision cataract surgery. One by one I'm going to tell you and give you the overview of this video. Just check it out here. Just a minute. Just going to check it out here, all the things. This is the eye, and we're given the verbal anesthesia. After giving the anesthesia, now I'm doing the peritomy. What is the mean of the peritomy? Peritomy, we have to remove the your conjunctiva. Okay, so this is the removal of the conjunctiva. You can see on the screen. So we are removing the conjunctiva here, right? So conjunctiva will be going to remove, and we are going to wash it. Why we are washing it? Because any kind of the bleeding or whatever will be here, it cannot enter into the eye, right? It will not enter into the eye. It will be not going to enter into the eye. Again, stop the video. Just a minute, guys. I think it's through the pencil. It is stopped. Just a minute, right? Yeah. So what we've done, we just cut it out. We cutted this. And after making the cut on it, now what we'll do? Now what we are doing? Now we are doing this. Now making an incision on it. Now what we are doing? We are making an incision on it. Okay. So making an incision on the clear cut on a sclera. Please understand, we are making the clear cut where? We are making the clear cut incision on the sclera. Okay, sclera. So now scleral cut will be given. And after the scleral cut, we are using this keratome blade. We are entering into the your we are going to entering into the your lens through the your sclerocorneal tunnel. We are making a corneoscleral tunnel. Through this corneoscleral tunnel, we are entering into the now where we are going to enter into. Just a minute, I'm moving into the fastly. We are entered into this your making this corneoscleral tunnel. We enter into the anterior chamber. After the making in the anterior chamber, we injected this trypsin blue dye, and this trypsin blue dye will be going to give the coloration to the your anterior part of the your lens. And now we have to remove this anterior part of the lens, which is known as the your capsule. We can know the capsulotomy. The anterior part of this capsule should be removed through this 26 gauge band needle. So you can see this is your capsulotomy is done. Through this capsulotomy is done. After doing this capsulotomy, now in the SICS, please remember, now in the SICS, what we are doing after doing this capsulotomy, we have to make the separation of your lens fibers, right? Your cortex, your nucleus should be separated from your capsule. So we are doing the irrigation of it. Okay, irrigation. Through the irrigation, what will we do? It will be getting the separation of it. And after doing the separation of it, after the making the separation of it, now what will we do? We check this. Yes, it is separated from your capsular bag. It's separated from the capsular bag. Now what we'll do, we'll use this irrigation rectus, and through this irrigation rectus, we are removing the cortex and the lens through the lens. Without the breaking it, we are removing this lens. So you can see this is the lens is removed, and some part of is left behind. The some part of your lenses remain behind, or cortex is remain behind. So now again, we will trying to aspirate it, or we have to use this irrigator rectus again and trying to removing it. Okay, trying to removing it wholly. Okay, so trying to removing it with this, you can see this with the irrigator rectus, we remove this part of nucleus. So this nucleus is getting removed, right? Some part of the cortex will be left behind. So removing this cortical lens, we'll use this bimanual irrigation cannulas, which is having the irrigation and aspiration, right? So you can see it is washing this anterior capsule cavity also, and aspirating also, right? So irrigation and aspiration should be done. As the irrigation and aspiration should be done, now what will be the last moment? The last moment, we have to enter a phakic lens, right? A phakic lens. The phakic lens should be entered into this cavity. So now the capsule bag is left behind. Now this in the capsule bag will place a lens, right? So placing this lens, you can see we'll use a non-foldable lens. Can you see this is the non-foldable lens? You can see with the using of the lens holding forceps, we are entering into this cavity, and this is entered into it. And we put it into the cavity. And after the putting it, please understand this thing. This is a small incision. Cataract surgery, we are not giving any kind of the suture. This is also a suture-less surgery. Just the suture-less surgery. We have to do the irrigation of this all the ports. We have to do the hydration of this all the ports. We do the hydration of this all the ports, and we'll put this conjunctiva again back to the normally. As it was it. And this is about your SICS. This is all about your SICS. No suture. Please remember, in the SICS also, we are not giving any suture, guys, here, right? Is it clear? So here SICS is completed. SICS, no sutures. Please remember, SICS में भी कोई suture नहीं देते. Okay. Now moving forward for the next one. This is your next one is known as your phacoemulsification. Just watch the video of the phacoemulsification also. Let's start with the phacoemulsification. I hope you remember this. So thus we are making a incision on the where we are making a corneal incision. We are making a clear cut corneal incision on the cornea. Can you see the clear cut corneal incision should be made with the keratome blade? And after making this, we given the intracameral anesthesia. Anesthesia will be injected into the cavity of it. And after that, we made this viscous, and after the viscous, we are now doing the capsulorhexis. In the capsulorhexis, we are removing the anterior part of the capsule to removing this fibers of the lens. So doing this capsulorhexis with your 26 gauge band needle, we are using the 26 gauge band needle. As the capsulorhexis will be done, after doing the capsulorhexis, now we have to do the irrigation, right? Irrigation, hydrodissection, which is known as hydrodissection. What will be done by the hydrodissection? We are putting this pressurizing normal saline will be there. So at what it will do, it will doing the separation of it. It will be doing the separation of your lens fiber through your capsule, right? So this will be going to separate it from it. It will be going to separate it from it. And after making the separation of it, now after making the separation of it, we are checking that nucleus is rotating. Yes, nucleus is rotating. Now it is the important step, which is the different here. Now we are entering into the phacoemulsification probe inside this lens, and we are trying to breaking this nucleus. We are break this nucleus into the small particles. As the breaking down of this small particles into this this nucleus will be divided into the small particles and getting aspirated by this phacoemulsification probe, right? So this will be the nucleus management of your phacoemulsification, which is the important part. Okay, important part. After doing this, all the part of the nucleus will be getting removed through this phacoemulsification probe. Just what will be left? Just the cortex will be left behind. And for the removing the cortex, guys, you already know what we have to do. We have to use the irrigation and aspiration. So for you will use here the bimanual cannulas will be getting used, and you can see this one is doing the irrigation, the second is doing the aspiration of this water, right? So irrigation and aspiration should be done, and after as the irrigation and aspiration should be done, your this cortex will be getting cleaned up. You can see this is the cortical cleaning should be done. As this cortical cleaning should be done, after this we have to enter this intraocular lens, and this IOL should be implanted as a foldable lens because the very small space will entering it, so we'll use the foldable lens. So this foldable lens will be put it inside, and it will be getting unfold inside the cavity, and we will place it. And after the placing it, just we have to do the hydration of the ports. Just will hydration of the ports. No suture should be given in this case also. So in this case of the phacoemulsification, also no suture should be given in this cases also. I hope you understand this very well, right? So this is the two procedures which you have to remember. Now I'm going to tell you the place of where you will placing your intraocular lens. It is also department. The first is known as anterior chamber, IOL. It means you will put this lens into the anterior chamber. Can you see? It is your iris and it is your cornea. So you place this IOL, you place this intraocular lens in between the lens. It will be between your cornea and the iris, right? So can you see it is there? But the second one is your PCIOL. It means the posterior chamber IOL. What is the posterior chamber? Posterior chamber behind the iris. So in the behind the iris, we are putting into your capsular bag, in the capsular bag. So as I shown you in your SICS, as I show you the SICS and your phaco, both are done in the PCIOL. Both are done in the PCIOL. If I'm talking about the ICCE, right? Intracapsular cataract excision. In the ICCE, when we are removing the capsule bag is removed. So now we have to put this IOL into your anterior chamber. We have to put this IOL into the anterior chamber, and this is all about the cataract. Now tell me if you have any queries related to the cataract. Let me know in the chat box. I'm waiting for your comments, guys. If you have any cataract related queries there. So this is all about the cataract. This is all about their cataract, right? Should we move forward? Okay, should we move forward? Moving forward for the next is your glaucoma. Talking about the glaucoma. In the glaucoma, it is a group of eye diseases. What is a group of eye diseases? Yes, there will be the causing of the visual loss, and the blindness can be there due to the damaging of your optic nerve. Due to the damaging of your optic nerve, it means the optic neuropathy. And why this optic nerve is getting damaged? Due to the increasing into the intraocular pressure. So the increasing into the IOP will be resulting into the what? It will be going to resulting into the optic neuropathy, and this optic neuropathy will be going to resulting into the vision loss. Okay, this optic neuropathy will be going to give the vision loss will be there. The next, the normal range. If you're talking about the normal range of your intraocular pressure, so normal range of your intraocular pressure is your 10 to 21 mm Hg should be your normal. The normal will be your 10 to 20 mm Hg, right? And how will be measured? As I already told you in the examination of the ocular examination chapter, that it is done by your from your tonometer, right? This is your aqueous humor outflow. In the aqueous humor outflow, you have to see the aqueous humor is producing from your ciliary body, and after the ciliary body, it is coming into the posterior chamber. After coming to the posterior chamber, it is coming through the pupil to your anterior chamber and flow till your angle of anterior chamber. At the angle of anterior chamber, we have the trabecular pathway, which is having the trabecular meshwork. We have this TB, trabecular meshwork. Okay, and after this trabecular meshwork, it will flow into your Schimm's canal, and now apicellary will be going to take this your aqueous humor through this, right? Aqueous humor will be taken by through this, right? So this is your aqueous flow. Now talking about the primary congenital glaucoma, what is happening in this primary congenital glaucoma? It is the type of the glaucoma. This occurs in the due to the trabecular, this is occurring is due to the your trabecular dysgenesis. It is occurring due to your trabecular dysgenesis. It means by the birth only the child is not having a perfect make of your trabecular meshwork. So as the trabecular meshwork is blocked, so it is not associated with the any other anomalies. Just only the trabecular meshwork can be trabecular dysgenesis will be there. It is if we're talking about the ratio male and female, it is having the 3:2. The male are the more commonly seen in the primary congenital glaucoma. Talking about the bilaterally, yes, in the 75 cases, 75% of the cases are having the bilateral primary congenital glaucoma. Talking about the symptoms, what will be the seen? Yes, the lacrimation will be seen, the first symptoms, and then photophobia and your baphlospasm. This is the triad of it. So the lacrimation, the continuously lacrimation will be seen. The patient is having the photophobia. The child is crying when he is going into the bright light. And the baphlospasm, yes, your eyelashes will be getting melting, right? And the third is your eye rubbing. The child is doing the eye rubbing. The next is having the sign. If I'm talking about the sign is the ophthalmos. What is the mean of ophthalmos? You can see this is the happening due to the increasing the intraocular pressure. The size of cornea will be getting increasing and getting clouded. It means getting the corneal edema also. So this eyes are looking a very big and the blue coloration. This is known as bulls, looking like a bull's eye. It is known as our ophthalmos. Bull's eye is looking like a ophthalmos. The next we have the upstria. As I told you in the keratoconus was the Vogel stria. So just remember with this, the Vogel stria was the first word, so it was the vertical stria. This is the H, so it is your having the your upstria is having the horizontal stria. So you can see in this image, this is having the horizontally strias are seen. This is known as seen in your particularly the case of your primary congenital glaucoma. If I'm talking about the diagnosis, yes, making the diagnosis will do the gonioscopic examination. Yes, I told you gonioscopy when we'll do in the gonioscopy will be in the in the cases of your glaucoma. So what will be the scene? There will be the thickening of their trabecular sheets. Yes, your trabecular meshwork is getting thickened, right? Because it is not made perfectly. So this will be the confirmatory diagnosis of your primary congenital glaucoma. And of course, what will be the treatment? You have to do the trabeculectomy. What you have to do? You have to do the trabeculotomy. It means you have to remove of your trabecular meshwork, right? So as the trabecular meshwork will be getting removed, so it will be directly connected to your Schimm's canal. So now from the angle of anterior chamber, all the fluid, the aqueous will be going to removed by the Schimm's canal. This is about the primary congenital glaucoma. Talking about the next, your primary open angle glaucoma. Starting with the open angle glaucoma, what is happening in the open angle glaucoma? Please understand, the open angle glaucoma is your angle will be getting open. Okay, angle is not the block. Angle is not the block. Angle will be getting open. And if we're talking about it, this having the IOP changes between having the 30 to 40 mm, 30 to 45 mm. Of course, the optic disc changes will be seen there. What is the optic disc changes? There will be the increase in the cup size. Okay, the cup size will be getting increased, and as the cup size will be getting increased, there will be seen in the increasing in the cup disc ratio. Cup disc ratio. Also, there will be the scene of the nasal shifting of the vessels. Nasal shifting of the vessels. And after the nasal shifting of the vessels, there will be the scene thinning of the neural rim. Okay, so the thinning of your neuroretinal rim. So thinning of the neuroretinal rim will be seen, and also there will be the scene of your visual field defects can be seen. As the visual field defects, yes, which kind of the visual field defect? You can see the paracentral scotoma. What is the paracentral scotoma? I can show you here. This is your eye. This is your blind spot, right, on the temporal side. So it is a temporal side, your blind spot. So it started as a small dots just above and the below of your blind spot. It is known as your paracentral scotoma. When your paracentral scotoma join with your blind spot, it is known as your saddle scotoma. It is known as your saddle scotoma, right? It will be seen on your temporal side. It will be your temporal side. If I'm talking about the nasal side, on the nasal side, the patient is feeling a step-like structure will be seen there. It is known as your Ronin's nasal step. It is known as your Ronin's nasal step. And now after it, when your saddle scotoma and the nasal step will be going to join together, it will be known as your arcuate scotoma, or known as the Bergeron scotoma. Arcuate scotoma or the Bergeron scotoma. It will be on the unilaterally, maybe superior side, maybe the inferior side, and when it will be having the two Bergeron scotomas will be there, it is known as the two Bergeron scotomas will be seen there. It is known as your ring scotoma, or can be say the double arcuate scotoma. And after this is known as the tunnel vision also. And after this also, the patient is not getting treated. The patient will getting the total scotoma. So the total blindness will be seen in these conditions, right? So starting with the paracentral, then saddle, then Brownell strap, then arcuate, then ring scotoma, or you can say the double arcuate scotoma and tunnel vision, and the last one will be your total scotoma will be seen there. If we're talking about the treatment, the topical treatment should be given as the pilocarpine should be given, and the latanoprost should be given. Your anti-glaucomic drugs from your pharmacology you studied well, so you can give this all the anti-glaucomic drugs in this patient. Talking about the surgery, yes, we have to do the surgery. In this case, we have to do the most common surgery is your trabeculectomy. Yes, we have to do the trabeculectomy. Surgery should be done in this cases, right? So if I'm talking about it, I'm showing you the perimetry report. So the perimetry, from the perimetry I will get the visual field, right? So you can see this visual field loss is seen, right? This kind of visual field loss is seen, and you can see this is the which type of, this is your arcuate scotoma. This is your arcuate scotoma, right? One arc is seen there. This is the arcuate scotoma, right? Last one, which is your primary angle closure glaucoma, which is your primary angle closure glaucoma, right? In this primary angle closure glaucoma, what we are having in this, the patient is having the hypermetropic eyes or having the shallow anterior chamber is the more risk factor, because as the shallow anterior chamber will be there, so it will be make the synecdoche easily. And what is happening as the eye is narrowing, so the angle of anterior chamber due to the small eyeball, it will be the relatively large crystalline lens. The lens is very large, so bigger size, so it will of the ciliary body, and it will what, it will make a synecdoche behind with it. So this iris will be going to make the synecdoche behind on the your lens, and it is known as your pupillary block. It is known as your pupillary block. Due to the pupillary block, if you're talking about it, the male are and the females are the more commonly getting this disease. This is the female dominated disease, moreover the seen in the female. The symptoms, talking about the symptoms, the severe pain and associated with the nausea and the vomiting will be seen in this patient. The sudden onset of the pain, please remember, the pain will be a sudden onset, okay? Sudden onset, okay? And if we're talking about the next, it is the color halos will be seen to the patient. The patient will be seen the color halos. If we're talking about the signs, what will be the sign will be seen? There will be the pupillary will be semi-dilated, or you can say the mid-dilated. It will remain the mid-dilated, and the vertical and the oval. You can see this is the vertically oval will be there, and it is fixed due on non-reactive on the bright light also. If I'm putting the bright light into it, it should be give me the constriction of it, but it is not constricting, right? It is not constricting. So this is your pupillary mid dilation. On the last is your intraocular pressure. Of course, the intraocular pressure will be increasing in this condition. Talking about the treatment, yes, on the treatment we'll do the gonioscopy. The gonioscopy, the angle will be closed, okay? Gonioscopy, in the gonioscopy angle will be closed, okay? Angle kaisa hoga? Closed hoga. The angle will be closed, and due to the closed angle, due to the closing of this angle, what will be the more seen with there? As the angle is getting closed, if we're talking about the treatment, the first drug should be given. It is your mannitol IV. Please remember, this is the 3 MCQs are given in the open in the angle closure glaucoma. Which is the first drug should be given? It is your mannitol IV. What is the drug of choice of angle? This is your pilocarpine. The pilocarpine should be given as the drug of choice. And if you're talking about the treatment of the choice is your peripheral iridotomy or the laser iridotomy. And you can see here, you can see on the peripheral of the iris or the peripheral of the iris, there is a making a hole. So we connected the bypass your posterior chamber to the anterior chamber. If in future there will be the synecdoche with this your pupil, and the lens will be there, so synecdoche will be made with this, so there will be the no effect of it, the aqueous will be can be flow to it. So this is about your glaucoma. This is about the glaucoma. Talking about the squint, so about the squint, the importantly I am going to tell you that you have to see the eyes, the squint you have to know about it. So squint, we are doing the Hirschberg test. I already told you, we will turn on the torch light and we have to see what, we have to see the reflex which is shown on the eye, and just the trophia will be just opposite. The squint is just opposite to your reflex where is going. So talking about the esotropia, it means the eye is turned inward. So as the eye is going inward, your reflex is going outward. Please understand, the eye reflex will be seen. Reflex is seen on the outward. The next is the exotropia. The eye is coming outward, right? The next is your hypertropia. The eye is moving upwards, and your last one is your hypertropia. Eye is moving downwards. The treatment of your squint, you have to do the muscle shortening surgeries. Muscle shortening surgery should be done in these cases, right? So this is all about our ophthalmology quick recap. So this is done with your ophthalmology recap. I hope you understand this, all the ophthalmology recap with it, right? It was quite good and interested for you. I hope it will be going to help you. What about the others? About the other of it, other topics which is left here, I already covered with this previous year topic MCQs, right? So you can find on the YouTube, my video is there. It is related to the previous year questions, right? I will surely send you the link also in the group. So you will watch that previous year questions, right? And it will be much better for you, right? That's it for today. Thank you.